My name is Michael Suk, and I wanted to wish you good morning and welcome to our symposium. I'm the chairman of the committee that's endeavored to bring this program to you today. I'm a third-year medical student at the University of Illinois while pursuing a joint degree in law and public health across the river at Boston University. You might say in some ways that this symposium is a form of self-expression or self-actualization, or at least some form of justification to my parents for their educational expenses. But on behalf of the Medical Society, the Massachusetts Medical Society Medical Student Section, I'd like to welcome you to this historic sharing of the stage between leaders of the American Medical Association, the American Bar Association, the American Public Health Association, and the U.S. Department of Health and Human Services. Our symposium, entitled "Can We Save Our Children? Where Law, Medicine, and Public Health Converge," is designed to stimulate a dialogue and discussion between you, the audience members, and our speakers at the highest levels of the organized professions and the government. This symposium was generated by the creative input and limitless energy of the Massachusetts Medical Society and the medical students that are part of that, believing that there is a vast, untapped reservoir of idealism in our communities that, if nurtured, honored, and provided with specific opportunities for action, can become a powerful source of action in combating tragic problems. With an interest in crossing boundaries that often separate our professional schools from our communities and that isolate professional disciplines from each other, we hope to unite a diverse range of professional students, faculty, and community-based providers who share a commitment to public service. The goals of this event are twofold. The first is to demonstrate public solidarity and to illustrate a commonality of goals between traditionally divergent groups on children's issues. The second is to educate our audience of professionals and students on organizational and government initiatives and help to empower us to be able to work in our local communities and work toward these goals. So can we save our children? By drawing on the expertise and leadership of three professional fields, I truly believe so, and I think you will too. In addition to the opening remarks, I have the pleasure of introducing our first guest, Dr. Francis X. Van Outen, President of the Massachusetts Medical Society. Dr. Van Outen is a staff radiologist at Emerson Hospital in Concord, consultant in radiology at Brigham and Women's Hospital in Boston, and clinical instructor of radiology at the Harvard Medical School. A cum laude graduate of both the College of Holy Cross and Georgetown University School of Medicine, Dr. Van Outen was elected to Alpha Sigma Nu, National Jesuit Honor Society at Holy Cross, and the Alpha Omega Alpha, a National Medical Honor Society at Georgetown. Following his internship at the University of Pittsburgh School of Medicine Presbyterian Hospital, he served in Vietnam and then at the U.S. Navy Hospital in Newport, Rhode Island. Please join me in welcoming a longtime friend of students and professionals alike, Dr. Rusty Van Outen. Thank you.
Thank you, and good morning. Welcome to you. It's my pleasure to welcome the Massachusetts Medical Society Medical Student Section's Spring Forum, Can We Save Our Children? I'm delighted to be here and participate in this exciting program. This morning we have four major organizations: American Medical Association, American Bar Association, the American Public Health Association, and the U.S. Department of Health and Human Services, coming together to discuss the common agenda of children's welfare. Here in Massachusetts, the Massachusetts Medical Society has been addressing the issue on a number of fronts. We've been working with the Massachusetts Society for the Prevention of Cruelty to Children on a project called Good Start. The goals of this program are to give disadvantaged students the opportunity to improve their chances of lifetime success by providing support in a variety of ways. The Medical Society has expanded its campaign against domestic violence to address all kinds of violence, including youth, domestic, street, and elder abuse. This spring we will be sponsoring a conference on youth violence directed to the healthcare specialists. In addition, the Physicians Roundtable on Domestic Violence will be holding a program entitled Supporting Battered Mothers and Their Children: What Physicians Need to Know. The Medical Society continues to promote childhood immunizations as a major health initiative in Massachusetts. It's also a longtime member of the Coalition of Health Education in Schools. I would like to express our appreciation to the co-sponsors of this event, Julie Wilson of the Malcolm Weiner Center for Social Policy at the Kennedy School of Government, and Heather Campion from the Institute of Politics at Harvard University. I would also like to express thanks to the Medical Society's Students section for initiating and organizing this impressive and ambitious program. It seems particularly appropriate that this idea originated with the Medical Students section, since they are the first generation to usher in the changes that are now occurring in America's healthcare system. And it bodes well for the rest of our profession. There we're taking a proactive role in collaborating with other professions in this major public health concern. The topic of children's welfare is heating up as a result of proposed cuts in social services and tough legislative initiatives at both the state and the national levels. These cuts will be affecting our most vulnerable population, our children. Our speakers this morning have been asked to focus on questions: what can we as professionals do to improve the state of our children's welfare? And what can concerned citizens do at a local level? It is my pleasure at this time to introduce my close friend and colleague, Dr. Robert McAfee, the President of the American Medical Association. He is an attending surgeon at the Maine Medical Center and Chief of Vascular Surgery at Mercy Hospital in Portland, Maine. He's also an Associate Professor of Surgery at the University of Vermont. Since taking office as the AMA President in June of this year, he's been an exemplary spokesperson for the AMA's campaign against family violence. Under Bob's leadership, the AMA has advanced its agenda in a variety of ways. Last March, the AMA sponsored the National Conference on Family Violence, Health and Justice. The conference focused on the relationship between health, justice, and the social service systems, and improving services and safety for survivors of violence. The proceedings of this conference are being compiled to be used for further education and public awareness. Dr. McAfee has also directed his attention toward improving physicians' awareness of domestic violence, and has encouraged physicians to be more assertive in addressing these problems in their individual practices. He was recently appointed by the American Bar Association's Commission on Domestic Violence, and he also serves on the Center of Disease Control's Advisory Committee on Injury Prevention and Control, as well as its subcommittee on Family and Intimate Violence Prevention. Ladies and gentlemen, it is my pleasure to introduce to you Dr. Bob McAfee.
Thank you very much, Rusty, and good morning, ladies and gentlemen. I do want you to know how very pleased I am to be with you this morning. When you're president of the AMA, you do have a significant travel schedule, and I will probably be on the road about 300 days this year, representing the association in this country and all over the world. But I have yet to turn down an opportunity to talk about violence, family violence, and particularly as it impacts on children. It's something which I think is long overdue as a public health issue of this country, and I hope that our legacy in this role will continue to put before the American public that this is not just a social problem, this is not a justice problem, but this is a public health problem that we have to address in the same fashion. With my travel schedule, at times I feel somewhat like the little boy who answered the telephone. A stranger called and said, hello, and the boy answered in a whispering voice, said, hello? He said, is your mother there? He said, yes, but she's busy. He said, well, is your father there? He says, yes, but he's busy too. Was there anybody else there? The policeman. Well, can I talk to him? He's busy. Is there anybody else there? Fireman. Let me talk to the fireman. He's busy too. Well, so I don't understand. Your mother, your father, the policeman, the fireman, they're all there. They're busy. What are they busy doing? He said, looking for me. So I sometimes have felt that way as the AMA tries to find me, as they did yesterday here in the hotel. I'm always amazed at children's ability to cope, and before we get into the substance, I Heard recently young parents could hear their 5-year-old son clump down the stairs. He had his brand new baseball bat, which was 3 sizes too big for him, and a new baseball, and he was going out in the backyard and practice a bit, and as he was clumping down the stairs, you could hear him muttering, "The greatest baseball player in the world is now going out to the backyard to play baseball." And parents were a little bit interested, so as he got out of the backyard, they went into the kitchen and looked out the window, and here he was tossing a ball up in the air, trying to hit it, and the bat was so heavy he missed it by about a foot, and said, you could hear him muttering again, "Well, the greatest baseball player in the world will try it again," and threw it up, and he missed it again. And then he gets ready for the 3rd time, and he said, "Well, bottom of the 9th, score is tied, World Series, Game 7. Greatest baseball player in the world is about ready." Throws it up, misses it again. He says, "Wow, what a pitcher, what a pitcher, what a pitcher." But on behalf of the AMA, let me extend my thanks to all who played a role in organizing this meeting today. I truly mean this. The reasons we must have conferences like this really appall me. For every abusive burn or bruise or broken bone that I see when treating children or hear about, for every abusive, diminishing word that assaults a child's ears and ego, there's always a moment when I really question humanity's survival. But that we are having conferences like this encourages me and makes me believe that together we can ensure the welfare of our children. Because at meetings like this, we, doctors, lawyers, government, public health leaders, put aside any vestige of territoriality and concentrate not on ourselves, but on our children. This meeting and a growing number of others like it around this country restore my faith in the inherent goodness of humans and really give me hope. And that Michael Zook, the AMA's student board member, and his colleagues at the Massachusetts Medical Society student section had the idealism and the commitment and the enthusiasm and the energy to put together such a collaborative conference as this, I think bodes well, not only for the future of medicine, but more importantly, for the future of our children. And I can easily answer the question this conference poses. Can we save our children? In 2 words, we must. You have asked us to tackle 2 other questions. How can our professions move beyond consensus to ensure our children's welfare? And what can concerned citizens do at the local level? I wish I had a 2-word response to these questions. I don't, but here are 4 words to get us, all of us, started. Concern, commitment, common cause. My comments this morning will be confined to the medical profession's role in saving our children. And let me assure you, we are concerned. We're concerned first, and I hope obviously, because we are compassionate humans. Beyond that, we are concerned because we are healers. And almost everything that imperils the welfare of our children, violence, mental and physical abuse, lack of immunizations, teenage pregnancy, AIDS, hunger, poverty, and drugs, just to mention a few, all have unfavorable medical consequences. And I'm sick and tired of being sent a bill for this violence in our society to the medical profession. And then when we turn around and tell the world what it is costing, the debate says we must change our health care system. Doctors are also concerned because we are pragmatic. If you take away nothing else this morning from our concern about child abuse and the violence in this country, please remember that there are more years of life lost to violence in our society than years of life lost to heart disease, cancer, and stroke combined. The reason being that violence takes its toll on young Americans. Violence is learned behavior. We have an opportunity. The cost of all violence in this country in 1992 was $13.5 billion. And whatever the cost of hunger and poverty and the forgotten childhoods of children who are addicted to drugs or who become parents before their time, it's too much. Our pragmatic side believes the figures published by Healthy Families America, a partnership program between the National Committee to Prevent Child Abuse and the Ronald McDonald Children's Charities. Healthy Family estimates that every dollar spent preventing child abuse saves $2 that would otherwise be spent on such things as medical care, counseling, and welfare services. So with our compassionate, healer, and pragmatic bona fides well established, let me tick off just a few of the things that organized medicine is currently doing in this particular arena. I think that you'll see that we have long since moved beyond fostering consensus the concern phase, to taking action, the commitment phase, but yet we have a long ways to go. And as you'll also see, that our action is not unilateral, it's inclusive and it's collaborative. The AMA has a long history on issues, as you know, concerning child welfare. We've been involved in issues as wide-ranging as lead and iron poisoning to reducing the alcohol content in medicines used by children. We've been advocates for childhood immunizations and parenting classes for adolescent children. Along those same lines, the AMA currently has supported the nomination of Dr. Henry Foster for U.S. Surgeon General because of his dedication to the challenges of teen pregnancy, drug and alcohol abuse, violence and infant mortality, all of which in his role has become subservient to the political discussion surrounding his nomination. The AMA, I am proud to say, plays a key leadership role in heightening the awareness of the American public to the issue of family violence. Let me define very briefly our definition so we don't confuse that this morning. We, by our definition of family violence, make reference to child physical abuse, child sexual abuse, domestic violence, and elderly abuse. We have difficulty in separating the continuum of violence that occurs in the family situation, and so I will use that term when, although we may be focusing on children, I don't think you can ignore the problems in domestic violence, because if you are a child growing up in a home in which your parents fight regularly, there's a 7 times likely chance that you are an abused child yourself. And of equal significance is that if you grow up in that family, there's a 10 times greater chance that when you become a parent, you will accept domestic violence and child abuse as a normal part of your daily existence. And that's why I think one can't talk about child abuse without looking at domestic abuse and what parents do and what parents teach. I remind you again that violence is learned behavior. We, the people of the United States of America, in order to form a more perfect union, will manage to kill 26,500 people by homicide this year in this country. 13,220 by handgun homicide. The next nearest country to us will be Canada, which will manage to kill 125, Japan 99, and we 13,220 by handguns. And we, the people of the United States of America, in order to assure our right to bear arms, are going to allow tomorrow in this country 100,000 children to go to school with a gun. A recent study done by Harvard, supported by Robert Wood Johnson, indicated in a survey across this country, both urban and rural children in grades 6 through 12, 67% said, I can get a gun in 24 hours. 4% say I carried a gun to school every day, and 9% of those children, kids, say that in my lifetime, however brief it has been, 9% said I have actually shot a gun at someone. Ladies and gentlemen, when it's easier to get a gun than a library card, we have a fundamental problem in this country. In October of 1991, the AMA launched its physicians campaign against family violence. It's now more than 7,000 members strong. There's nothing quite like it. The campaign materials include materials physicians receive when they join include information about resources, model programs, speakers, and public education. The members of the campaign receive the AMA diagnostic and treatment guidelines on child and elderly abuse and domestic violence, child physical abuse, child sexual abuse, domestic violence, and elderly abuse and neglect. If you ever need an example of the solidarity of the medical profession, this is it. Let me remind you of some of the groups which are involved in developing and endorsing and supporting the use of these guidelines. Their names form an honor roll of American medicine. The American College of Physicians, the American College of Obstetricians and Gynecologists, American Academy of Pediatrics, the American Psychiatric Association, the American College of Emergency Physicians, and the American Academy of Family Physicians were all part of developing and endorsing and supporting the use of these guidelines. I brought a few copies of the Child Physical and Sexual Abuse Guidelines out here for those of you to take away, and I'll tell you how to get a complete set in a minute. I've also brought a few copies of the AMA Guidelines for Adolescent Preventive Services, which spells GAPS. These GAPS guidelines help physicians establish policies for caring for adolescents and how to involve their parents in that care. In January of 1992, American Medical News, the AMA's weekly newspaper, devoted an entire theme issue to family violence. It was unheard of for our newspaper for a single topic for that week and nothing else. We have had the highest request for reprints from that newspaper than from any publication we've ever had, and the AMA is the world's largest medical publisher. At the same time, we went to Dr. Lundberg, the editor of JAMA, and suggested a theme issue of JAMA dealing with family violence. He said, "Bob, I need 8 to 10 peer-reviewed manuscripts to make a theme issue, and I'm not so sure I can get them." "George, you're not going to know till you ask," and so he asked. And within 2 months' time, there was 122 manuscripts submitted, which on peer review, 88 were felt to be in need of urgent publication. And so not one but 2 issues of JAMA, and then every single specialty issue, the 7 specialty journals that we publish monthly in the month of June of '92, were totally devoted to violence and trauma, psychiatry, ophthalmology, internal medicine, surgery, etc. All those papers have been bound into a single volume called Violence, which serves as a significant basic document for anyone interested in this plan, and is available from the AMA. And this June, there will be another theme issue on JAMA on family violence, updating the recommendations and where we now stand. In January and again in June of '92, along with then Surgeon General Dr. Antonio Novello, I met with members of the media to help heighten their sensitivity on the issue of family violence. And by and large, their response in the media has been excellent, and I commend them for their concern. We realized that our efforts would be enhanced by involving a variety of local agencies, and so we published What You Can Do About Family Violence, which is a publication to showcase the work of our local and state and specialty medical societies, what they are doing to prevent and reduce domestic violence. And 2 years ago, in March and April of '93, the AMA-led National Advisory Council on Family Violence met in Washington. Dr. Dick Jones from Hartford, Connecticut, president of American College of OB/GYN at that time, and I, along with representatives of 30 other medical specialties, planned a national multidisciplinary conference about the legal and the medical issues of family violence. And then, in March of this year, that meeting occurred. It was 4 days of high-powered presentations for physicians and lawyers, and importantly, the media. Attorney General Reno, Secretary Shalelis, Surgeon General Dr. Elders were among the dozens of presenters at that meeting. We had 83 co-sponsors, from the American Dental Association to the U.S. Conference of Mayors, from the American Pharmaceutical to Parents Anonymous. There were 15 participating organizations who were medical, legal, governmental, religious, education, public health, etc. Now, that meeting resulted in a lot of recommendations, and the AMA is working to implement them. One of the most encouraging projects to come out of this conference is the development of a guide to help communities mobilize, at the local level, multidisciplinary councils made up of physicians, law enforcement officers, judges, and social workers. Another positive result of the conference are 4 regional meetings scheduled to take place in 1996, a Train the Trainers conference. These will be held in Boston, Atlanta, Chicago, and probably San Francisco. The American Bar Association's immediate past president, Mr. Bill Ide, attended our national conference, joined me in welcoming the participants, and as a result, the ABA published their own study recently, which I commend them for, quote, "The Impact of Domestic Violence on Children," and I'm sure Ms. Ramo will talk to you about that today. It's excellent, and I urge you all to read it for yourselves. Roberta Cooper Ramo is the ABA's president-elect, and I must tell you how dynamic and enthusiastic she is when it comes to the matters of family violence. She's been most supportive of our efforts, and it's been a delight for us to interact with the ABA, and I'm very pleased to represent the AMA on the ABA's Committee on Domestic Violence, and look forward to continuing good relationships there. An ABA representative also sits on our National Advisory Council on Family Violence. Another issue of critical importance to the welfare of our children is the degree of violence and sex on television. The AMA supports, along with more than 24 health, education, and community groups, Senator Ken Conrad's, quote, "Children's Media Protection Act." We joined the senator at a press conference just about a month ago to support the bill, which calls for installation of a so-called violence chip, or a V-chip, in television sets so parents can block violent or other objectionable programs. Last year, your congressperson from Massachusetts, Ed Markey, had a similar bill in the House, which he hopes to reintroduce again this year, asking for this simple bit of technology to be installed in much the same way the closed captioning chip is installed that would allow parents, particularly single parents, to program out, having identified those violent programs that day, that should not be shown to the 4-year-old child in that home. This is not censorship. This does not prevent those who make the programming continue to make violent programming, but it's helping parents parent. And in 1995, God knows, they need all the help they can get. We support FCC rules for rating the level of violence on television programs. We want to see gratuitous violence prohibited between early morning and 10 p.m. at night. And the root causes of violence are varied and debatable, but over the past 2 decades, a growing body of evidence has documented the relationship between the mass media and violent behavior. We want a new rating system for children of the mass media: television, motion pictures, rap music, video games. 12 and under isn't good enough. Remember, if you will, the movie Home Alone. A 10 or 12-year-old child can witness that and appreciate that as slapstick. But a 4-year-old child seeing for the first time a 10-year-old boy hit a man on the head with a brick, burn his scalp with a blowtorch, make him fall down the slippery stairs and hurt his back, creates a totally different image at age 4. And if you don't believe it, let me ask this audience, as young as it is, how many of you remember when Bambi's mother died? For most older people, that's left a lifetime of trauma. Not because it was graphic violence. His mother went over the hill, you heard a gunshot wound. The stag father said, "She won't be back, we must move on." And Bambi cried, and we cried, and we've remembered it for a lifetime, because you and I were much closer to age 4 when we saw that motion picture for the first time. And that's the point we're trying to make. That even in the crass programming that comes into our homes every day, there still is an opportunity to diminish to the 4-year-old the impact on that. And someone much wiser than I, of which there are many in this country, has told me that the very precious preventive dollars we have available to us in violence should not be spent on anyone over the age of 6. Because if we can't convince a child by the time they get to school that there are alternatives to violent programming, then it's going to cost us a whole bunch of money down the road to reverse the acceptance of violence in that individual's life. I point out to you similarly that the AMA is a co-sponsor of Voices Against Violence Week, which is March 19th through the 25th, sponsored by the nation's cable television programmers. This month, I hope that you will see a diminution in violence during that particular time. See if you notice a difference. Have we moved beyond consensus? I think the answer to that is obvious and clear, but let me state again for the record, yes, we have. And now we're engaged in a common cause that's broad and deep. If there's an organization out there still debating whether family violence is destroying our nation's children, I'm not aware of it. It is tremendously encouraging to see the power of this cause. And as you know, doctors and lawyers don't always see eye to eye, but on this issue, we are in complete agreement that action is required. And both groups, each in their own way, are working at the national and local level to do something about child welfare issues. Let me tell you just about a few of these AMA's local efforts. Our alliance, which is the name of our auxiliary, our spouses organization, wholeheartedly embraces the concept of reducing violence and enhancing the welfare of our children. I could spend an hour telling you what they are currently doing. The National Alliance produces a series of coloring books dealing with safety, exercise, nutrition, and conflict resolution. For a 5- and 6-year-old to be said, yes, you can choose. So that when Johnny pushes you off the slide the first day of school, you don't go and push Johnny back. You don't go and get somebody else to help you push Johnny back. You go and play with someone else. And for the child who colors in the most violent option in each of these pages, you have told the kindergarten teacher where her problems are going to lie that year. And yet for those children need to be made aware of their independence and their value system, even at that precious young age. The California Alliance recently distributed 35,000 cards with a crisis line 1-800 number on them for domestic violence victims. There's a home for abused teenage girls in Alabama that's there simply thanks to the state's alliance. And other state alliances develop resource guides for physicians, hold forums to educate the public, and create television infomercials to get information about abuse to the right audience. And all in all, during 1994, there were more than 850 alliance initiatives underway in 40 states across this country. We're very pleased. They've only begun. There'll be a major initiative begun this fall called SAVE, Stop Americans Violence Everywhere, and you'll hear more about that then. We at the county and the state level, in conjunction with the alliance groups, in collaboration with specialty groups, begin to seek out those who see the effects of violence, of abuse, of hunger and poverty, and enlist them in an effort to save our children. We must reach out to the law enforcement agencies, the schools, the courts, and other medical caregivers, especially dentists and pharmacists, who are in a unique way and a unique spot can contribute to the solution of this problem. We've got to make sure the schools and the business community know of our interest and our concern and our willingness to be partners with them. We must live up to the trust that our patients put in us by learning as much as possible about domestic violence. 2,000 American children are beaten and starved to death every year in this country. Millions more suffer the horrific effects of ongoing abuse and neglect. And I'm sorry to say, it's hard to measure how many million more victims there are because physicians fail to identify as many as 90% of the victims of domestic violence. It will take more than good medicine to ensure the welfare of our children. Physicians must become fully aware of their resources available to them and their patients. And if you don't have a reference list in your office that includes shelters, legal advocates, counselors, support groups, crisis hotlines, the 800 numbers, the committee leaders in your state alliance, then get that list assembled, fellow doctors, because that's your responsibility. Join the National Coalition of Physicians Against Family Violence. It's easy. Just call 312-464-5066 and ask for Jean Owens. That's the AMA's number in Washington, her extension 5066. The only cost is your commitment to help curb family violence. The payback is tremendous, and we assure the welfare of our children and the future of our society if you will join us. Less than 2 weeks ago, a young mother, 23 years old, stood on a bridge over the harbor in Long Beach, California. Donna Jean Fleming was not alone. Craig Allen, her 2-year-old son, was with her. Michael Robert, her 3-year-old son, was with her. And as a passerby watched, helpless, as Donna Jean Fleming picked up her first one and then the other of her babies and dropped them 30 feet into the waters of the Los Angeles River. Then she jumped after them. Craig Allen died. Michael and his mother were rescued. Stories like this should appall us, and they do, but they're becoming ever more commonplace. And with every recounting of such horrors, we build up a bit of a callus. Our emotional skin thickens. It's an inexorable process. Little by little, the violence and the poverty and the heartlessness that assault our senses causes us to become insensitive. Our role, we healers, we lawyers, we social service workers, is to see to it that the nerves which connect our senses to our conscience never become desensitized. If we do not, ourselves, our nation, and yes, our children and civilization begins a decline into darkness. We can stop it any time. We have an inexhaustible source of light at our disposal: the love, the life, and the laughter of our children. But for the children's light to shine, we must first ensure their welfare. We, all of us working together, owe it to them, and we owe it to ourselves, and we owe it to the future. I have many hopes for mankind, but none more poignant than the hope that I hold in my lifetime that I will never again have to read about mothers tossing their babies into dark rivers. It will take missionary zeal to make it happen, but it can happen. The story is told in Maine of on a summer's day at noon, an older woman seen scurrying along the beach, picking up something and throwing it into the ocean. And as a passerby stopped her, it was apparent that there were thousands and thousands of starfish that had washed ashore during that tide. And as the tide was receding and the sun baking down, it was obvious that these starfish would not survive till the next tide. And a passerby stopped her and said, "Madam, I don't understand what you're doing." He said, "As I look, there are miles and miles of beaches here, and there must be tens of thousands of starfish. How can you possibly think that picking them up and throwing them back, as you are doing quickly, can possibly make a difference?" And she reached down and she picked up another starfish and she held it out to the stranger and said, "Well, for this starfish, it makes all the difference in the world." And she gently tossed it back into the ocean. Ladies and gentlemen, the challenge is there for you and I and the doctors of this country. Join me in this crusade. Save our children and make them safe. Thank you very much.
Good morning, and thank you for your participation in our program on children. Violence is a problem blind to economic and social barriers, which makes it particularly important that we demonstrate the commitment of the gathered organizations. I am Bonnie Hartstein, and I am in my second year at Boston University School of Medicine. I've also been nominated by the American Medical Association Student Section to be the student member on the AMA's Council on Ethical and Judicial Affairs. It is my great honor to introduce to you today Roberta Cooper Ramo, President-elect of the American Bar Association and the first woman to head the organization in its 116-year history. Ms. Ramo is a graduate, magna cum laude, from the University of Colorado. She earned her law degree from the University of Chicago. Named one of the best lawyers in America in corporate law, Ms. Ramo's diverse legal career has taken her from small firm and solo practice to partnership with New Mexico's largest law firm. As past president of the Albuquerque Bar Association and former chair of the ABA's Law Practice Management Section, she has been active in national, state, and local bar associations. She's a two-time recipient of the State Bar of New Mexico's Outstanding Contribution Award. Ms. Ramo is also very active in her community. She was president of the University of New Mexico Board of Regents from 1991 to 1993. Among other community activities, Ms. Ramo serves as president of the New Mexico Symphony Orchestra Board and is on the executive committee of the Albuquerque Community Foundation. In 1993, she received the Governor's Distinguished Public Service Award for community service in New Mexico. Ms. Ramo hopes to lead the ABA to improve public's understanding of the law and to improve our system of justice. She has, for example, appointed a task force on domestic violence to recommend legislative and judicial reforms to protect partners and children from abuse and to stop the intergenerational cycle of violence. She also hopes to invigorate the ABA to become more responsive to the needs of the profession, in particular, lawyers in small firm and solo practice, and to broaden the ABA's service to the public at large. It is my great pleasure to bring you Roberta Cooper Ramo.
Well, that was a wonderful and overly generous introduction. My only regret is that neither my husband nor my mother-in-law were here to hear it. Perhaps if I'm choked up, I want to tell you it's not only the subject that would choke up anyone, but the fact that if I go more than 24 hours without green chili, my hands start to shake, and I've been gone over long from New Mexico. Perhaps only a lawyer would have the temerity to come to Harvard and the Massachusetts Medical Society and suggest that the name of the program to which she was invited is off the mark. But with deep humility, and I say that sort of in the same way that I know when someone asks me a question that starts out with all due respect, what makes me concerned is that I must tell you I think to some extent it is. It was really the second clause of the original program, Michael, that made me think that we needed to broaden our focus a little bit. Addressing child welfare issues is really not enough in the narrow sense. While it's true without a shadow of a doubt that the children most at risk in our society today are our poorest children, I want to broaden our focus for a few minutes and suggest that maybe our very poorest children are at risk in some part because we have become a society that talks about family values but is not organized in any way to promote them. If the poorest children in our country are at the outer banks of the richness that is American education and medicine and law, far from the deposits of our natural resources, including human dignity and respect and the diversity that the American population has, it's in some part because our whole nation, in a very un-American way for the can-do society, has substituted sloganeering for problem solving, and blame and old movies about a society that never really existed for a hard look at the life we are actually living. If child rearing in America were a river, it is a very narrow stretch that has the proper depth and that nurtures only a small number of our children in the very best way. So while I am anxious and ready and willing to address the legal issues posed in today's discussion, and to enroll with you in the army of professionals absolutely determined to take the flood of errors we've made in the past and fight it with our best ideas and our joint professional skills, I must also use today's unusual platform to talk about what we must do in our professions for our own children. First, let me explain that just as effective physicians today are called to tend to illness in settings they were not trained for, American lawyers and courts find themselves under siege with a deluge of cases dealing with children in situations not contemplated in any way by the language of the law, nor funded or organized to take care of the cases, particularly dealing with children that are in front of them. And neither the law nor the situations are understood by the American people. How do the same laws deal with 7-year-old twins caught in New Jersey last week for the third break-in of a church, and 17-year-old brothers accused of murdering their parents and 11-year-old brother? What courts are really prepared to deal with 9-year-olds who bring guns and knives to school, early adolescents with pagers recruited to do drug deals because their only slightly older mentors know that if caught, the worst thing that will happen to these children is that they will be sent in some places to a reform school where they may actually get the first 3 organized meals a day that they have ever had in their lives? How do we train lawyers to deal with children as clients? Children who can't speak in any language but the streets. Children who come from homes where it is easier, in fact, to live on the street than to survive child abuse or witness domestic violence. A few statistics will give you the dimension of the legal problems that we're faced with in this country. 1 of 5 children American children live below the standards defined as bare subsistence. 1 in 4 lives in poverty. 63% of all African American babies are born to unwed mothers, and 18% of all Caucasian babies. That matters because children in single-parent households are far more likely to be poor than those in 2-parent homes. And it is important to understand that this is a very recent phenomenon in all races and all cultures. Gunshot wounds are the leading cause of death among both African American and Caucasian teenage boys in America. Poor, or in many cases absolutely no parenting, have caused our state courts to be overwhelmed by cases involving families and children. Federal legislation, and even that in many states, place burdens on the courts without any additional funding or thought about the type of court or court proceeding that ought to deal with the problems of children. In Chicago, juvenile court judges hear 1,700 cases a month. In Los Angeles, juvenile court judges have about 10 minutes to devote to each case in front of them. Children often find themselves in court without the benefit of legal counsel, and children detained before and after trial are often placed in overcrowded facilities which fail to provide adequate health care and in which the only education that they get while they are there comes from their fellows, who teach most frequently increased violence and more effective criminal behavior. At the same time, all of us are exhausted from the violence that has become an expectation in American society. And it is clear that the norms of childhood behavior which produce the current juvenile laws do not exist in much of society today, where the idea of having a family being in charge of basic discipline is obviously not an operating principle in large segments of our communities. The more we look into the root causes of violent criminal behavior of children, the more we see the footprint of domestic violence. What we have discovered is that the forgotten victims of domestic violence are the children who watch it. If we don't intervene, they are often doomed to repeat the cycle. the boys as violent abusers and the girls as women who think being hurt is a normal part of any relationship with a man. Every day, some children watch as their mother is threatened or beaten, and every week or so, some children lose their mothers forever when beatings escalate to murder. Every day, police go on their most dangerous calls, family violence, and sometimes batterers are arrested and prosecuted, and sometimes not. What we've overlooked as a nation is the cost to each of us of losing these children's ideals of society, of respectful relations between men and women in their lives. We need, in social and economic terms, to understand the enormous cost of losing the potential of a child to grow into a productive adult. A man to understand that it is possible to be angry and not hurt the woman in his life. A woman who knows it is not a normal sign of love to be hurt. The American Medical Society last March announced that violence was the #1 health problem of American women. And they also described the symptoms of domestic violence with a set of medical symptoms that could be recognized by a physician, in the same way that they bravely described child abuse over 20 years ago. In August, as Dr. McAfee indicated, the American Bar Association received a stunning report on the impact of domestic violence on children. Today, I'm happy to tell you that the American Bar Association Commission on Domestic Violence a month ago had its first meeting. And I want to tell you who is on that commission because I am so pleased and proud that we are joining with the American Medical Association, Dr. McAfee as its representative, with the president of the NEA, the president of the American Psychological Association, Judith Kaye, the chief judge of New York, and an executive of the Walt Disney Corporation, and the superintendent, which is the police chief of the city of Chicago, along with many other very distinguished national leaders, to issue not a report, but actually to give us a paradigm of resources for communities to emulate, so that we hope by August of 1996 there will not be a community in America that does not know how to bring together in an effective way all of the resources in that community to deal with domestic violence. Lawyers and physicians are joined to begin to stop the violence that hurts millions of families every day. And I think as we look more and more into it, it is that violence in the family that sows most of the seeds of criminal behavior that the rest of society reaps every day. The American Bar Association, with guidance from the Commission, will recommend far-reaching changes in statutes that deal with child custody, the handling of criminal cases related to domestic violence. We are organizing free legal representation for battered spouses and children who are the victims of abuse. And we're working with the Legal Services Corporation to save federal funding for programs in this area for the poor. And we hope to initiate with the American Medical Association joint programs that are sponsored both by the AMA and the ABA. We, the doctors and lawyers of the AMA and the ABA, will talk with those social workers and community activists across America who have labored so long with so few resources to take in battered spouses and their children, to see what support they need and what programs work the best. We'll sit down with juvenile court judges and establish how often they believe juvenile violence is linked to violence in the home. We are working to unify the courts that deal with all aspects of families in trouble, juvenile, criminal, and family courts. We will help make sure that our hospital emergency room personnel know how to recognize the syndrome and what to do when they see it. We will talk, all of us, until it is no more socially acceptable to allow a child to witness violence in the home than it would be to throw a child into a car with a drunk. Then maybe someday in every city and every village we'll be aware enough to see the violence coming and stop it before it takes away the trust that every child should have when they think of mom or dad or home. If the rule of law can't protect children in their own homes, then the rest won't seem very important. Lawyers are all, each and every one of us, officers of the court. And we know that if there is not peace and protection from violence in our homes, then the rule of law will become inconsequential, and our American democracy can't afford that. One of the things that we're doing to try to reduce violence is to go to the schools. The American Bar Association has a program which teaches peer mediation or alternative dispute resolution in the middle schools and high schools all across the nation. Just to give you an example of the kind of impact this can have, in a South Carolina high school in which they had an enormous problem with violence, when they went in over the course of a year and taught peer mediation and alternative dispute resolution, the very next year they found only 30% of the number of students from the year before were dismissed from school because of violent activities. Tragically, what we have discovered is that these kids don't have any other model of solving their problems. The models they see in front of them in their homes, in their communities, and as Dr. McAfee said, all too often on television and in the movies, the model given to them by the contemporary heroes are models of violence. And it's taken us a while to figure out that we actually have to teach in our schools that there are other ways to solve problems. On September 17th, a day I'm sure well known to each of you, a national holiday, Constitution Day, mark that on your calendars, the American Bar Association is going to kick off a year-long series of activities that will culminate in Law Day, in which in every one of the 50 states we will have lawyers in the high schools and middle schools of the states teaching alternatives to violence, how to make rules in a peaceful way, and not just to deal with the fact that we've become a nation, I fear sometime, of constitutional illiterates, but more importantly to make sure that all of the children have some idea that violence is not the norm and not the only way. Let me use this platform today to say a word about the Legal Services Corporation. As many of you know, the Legal Services Corporation is that federal agency which, using only 3% of its money for administrative purposes, takes 97% of its money and gives it out to the local communities to make sure that there's legal representation for the poor. It is tragically one of the programs that the Congress has chosen to target. Ironically, today, when we're talking about issues of child welfare, you should know that one of the issues that has made many people in the Congress the most upset with the Legal Services Corporation is that a Legal Services Corporation lawyer in New Jersey was so bold as to take the New Jersey state legislature to court because they felt that issues dealing with child welfare in particular were not handled right in their own welfare reform, and that has tended to infuriate many members of Congress who think that the only answer is to make sure that there is no Legal Services Corporation, no legal services federally funded for the poor among us. One of the many places that doctors and lawyers need to work together is to save the Legal Services Corporation's funding. Much of the work they do is related to the representation of children in civil matters, or to those rights that often affect children directly. For example, dealing with victims of domestic violence, dealing with things such as being evicted from their homes. I think in this setting it's important for me to say also a word for the legal profession. America is the most heterogeneous society that the world has ever known. People of different races, religions, and cultural backgrounds rub up against each other every day. And that we do so usually in incredible peace has allowed us to be the most prosperous country in the world and a model of freedom. If we are not perfect as a society, it's because we are still evolving, still finding ways to deal with racism and gender bias and violence and suspicion between people as different as many of us are. But American ideals cut across our differences and our shared values that make us strong as a nation. The United States Constitution, the Bill of Rights, our courts, and the independent practice of law make all of that possible. We all, including the poorest among us, have the right to have our conflicts resolved in courts where a judge listens, holds forth nothing but ideas of fairness, and hears the pleas of people on both sides. Now back to where I started. Between our two professions, medicine and the law, we represent the most well-educated of our society, each with social responsibility as the cornerstone of what we do. How, we must ask, do we treat our own children? What kind of parents are we doctors and we lawyers? Let me suggest to you medical students that nothing you do will ever be more important than the kind of parent you are. Women are in a world where it is easy to be attacked as a bad mother if you have a professional life. And men often feel that they do not have the range of professional choices in either of our professions that allow a serious time commitment to parenting. I offer my own husband, who is a physician, as a medical role model. He is a man who loves his children, his students, and his patients. A man who, when our children were young, made time for dinner on all nights when someone was not under emergency care, and even though it meant many nights, he went back to very late nights at the hospital. He arranged his call schedule so that he could take care of child care when I was gone, and has, as a result, a kind of rich relationship with his own children that I think many of the physicians in our community marvel at and wonder exactly how it happened. And it happened the old-fashioned way. He worked at it. We must work to not go back to a world that never was, in which somehow we had this ideal that mothers were perfectly happy staying at home all day with no professional lives of their own, and that fathers were better off not coming into the home except to bring their paychecks. We must work to demand family-friendly policies in our academic settings and in private practice. In a world in which technology was supposed to make things easier in our lives, we find ourselves instead with work impinging upon every second of our time. The fax machine, I am quite convinced, is an instrument of the devil. And the expectation of instant resolution of medical and legal crises is something that we all have to figure out a way to deal with. We must take back time for family life, and at the same time understand that all children do not have well-educated or even caring parents. And those children without you and I as their biologic parents must become our children too. We must reject the facile sloganeering that rejects ideas of prevention, crime prevention, as somehow fuzzy-headed liberalism. The idea of trying to prevent criminal behavior is no more ridiculous than working to prevent cancer or polio. Criminal violence is a plague on our country, visited often on children, and support for prevention has to be there, not only for punishment. The fact of the matter is that we cannot build jail cells fast enough to allow for the incarceration of all of the children we are allowing to be infected with the imprint of criminal behavior as the norm in American life. What is remarkable about this last year is that with the help of Bob McAfee from the American Medical Association, your own Michael Sook, and Dr. Van Houten, who's been so wonderful in allowing the Massachusetts Medical Society to be the host for the event today, the doctors and lawyers of this country are joined in a unified crusade to make violence in America, especially violence targeted at our children, no more our apple pie, but instead our polio, deadly and no longer a threat. Thank you.
Thank you very much, Ms. Ramo. And thank you to all of you for joining us here today on this rather momentous occasion to share in our concern over our country's children. My name is Rick Rapetta, and I'm a second-year student at Tufts University. I'm particularly honored to introduce our next speaker in the fact that I'm also studying for a Master's in Public Health degree. And some of the issues that he'll be discussing I'm particularly aware of in terms of poverty and how that affects children's health. Dr. Richard Brown, the president-elect of the APHA, is currently the director of the UCLA Center for Health Policy Research and professor of public health at the UCLA School of Public Health. He's also served as a senior consultant to the President's Task Force on National Health Care Reform in 1993 and co-chaired a work group on coverage for low-income families and individuals. He has also developed bills in the California legislature and in the United States Senate, where he is now a fellow and health policy advisor to Senator Paul Wellstone. He has presented invited testimony to numerous committees in both houses of the U.S. Congress and in the California legislature, and has provided consultation to private, state, federal, and international agencies. And so it is with great pleasure that I introduce to you the President-elect of the American Public Health Association, Dr. Richard Brown.
Thank you, Rick. It's a pleasure to be here with my colleagues in law and medicine and the U.S. Department of Health and Human Services. And I'm going to focus on a slightly different aspect of children's health this morning. Violence is clearly a critical problem. It's a plague that is sweeping our country, affecting people of every age, and particularly our children. But poverty is also a critical problem facing our society. Poverty is one of the major causes of poor health among America's children, and poverty among children is growing and deepening. In my presentation, I will focus on some of the main indicators of children's health, how poverty influences children's health, and how health services and public policy, the joint domains of public health, medicine, and law, can improve the health conditions that affect children. As Drs. Paul Wise and Alan Myers have shown, poverty affects children's health in two ways. First, poverty increases the risk of an illness or injury occurring, or it increases the risk of the severity of that illness or condition as well. Secondly, poverty reduces children's access to health services and other kinds of interventions that can prevent or ameliorate the effects of illness or injury. It is instructive to examine the influence of poverty on infants' chances for survival. Infant mortality is a sensitive indicator of social conditions in any society, and the United States does not fare very well in comparisons with other countries. We rank 20th in the world in our infant mortality rate. Nearly two-thirds of infant deaths in the United States occur in the neonatal period, the first month of life. The most powerful indicator, the most powerful predictor of neonatal infant death is low birth weight. As with infant mortality, the U.S. compares poorly with other nations of the world, 22 of which have better low birth weight rates than we do. Within the U.S., infant mortality rates differ significantly and dramatically by race. African American infants are more than twice as likely to die in the neonatal and post-neonatal periods as are white babies, a relative difference that has persisted for decades despite declining death rates. To a large extent, race is a surrogate for poverty in vital statistics because we tend not to collect information about social class or family income. Most of these differences by race are due to more extensive and deeper poverty among African Americans and the social conditions that poverty brings with it. Poverty is a major predictor of low birth weight, approximately doubling the risk of having a low birth weight baby. African American mothers are more than twice as likely as white mothers to have a low birth weight baby. Poverty is associated with higher rates of prematurity and retarded intrauterine growth. As Drs. Wise and Myers point out, the effect of poverty on birth outcomes may represent in part a legacy of inferior health status of poor women. Both prior to conception and during pregnancy, poor women are more likely to suffer from poor nutrition, increased stress, obstetric complications, poor general health status, and health-damaging behaviors such as cigarette smoking and alcohol and drug abuse. Poverty also affects post-neonatal mortality, particularly by increasing the risk of sudden infant death syndrome. Although poverty is an important predictor of low birth weight and infant mortality, medical and social interventions can prevent or ameliorate these outcomes. Providing comprehensive prenatal care, including medical monitoring, health counseling, and family support, beginning early in pregnancy reduces the risk of low birth weight. The value of adequate access to prenatal care has been demonstrated repeatedly with a variety of populations. Poverty, however, reduces access to prenatal care. Only 62% of African American women receive prenatal care during the first trimester of pregnancy, compared with 80% of white women. Low-income women have poorer prenatal care access because they are more likely to be uninsured, face other financial barriers, lack a regular provider of care, face non-financial barriers such as lack of transportation and long waits to get appointments for prenatal care. Extensions of Medicaid coverage to all poor pregnant women and to many above the poverty line in many states have improved access to prenatal care. But these policy changes have been implemented only in the last few years. In Los Angeles, for example, a program developed by the Los Angeles County Department of Health Services coordinated public and private sector prenatal and obstetric care for low-income women, resulting in a drop in infant mortality rates. And in semi-rural upstate New York, a randomized trial of nurse home visits to young, low-income pregnant women with continuing visits during the infancy of their babies decreased smoking rates, improved diets, increased birth weights, and dramatically decreased child abuse and emergency room visits. Within 2 years after the program ended, the program saved more than it cost, a net savings of $180 per low-income family. For decades, we have intervened with expensive neonatal technologies to save low birth weight babies. Neonatal intensive care has been effective in increasing the survival rate of low birth weight and other high-risk infants. These technological interventions following birth have reduced the influence of poverty on survival of low birth weight babies, but they are extraordinarily expensive, and in effect, they lower the risk of death during the neonatal period in exchange for increased risk of severe disability and disadvantage during the post-neonatal period and childhood. Compared with normal birth weight babies, low birth weight infants are 3 times more likely to develop serious neurological handicaps, and they are more likely to develop lower respiratory tract infections, chronic pulmonary disease, and other serious medical conditions. Among surviving low birth weight infants, poverty increases the risk of post-neonatal mortality and poor performance in school. We can intervene early to prevent these conditions, and we also must address the fundamental cause of these conditions for many women, which includes poverty. Low-income children are at a greater risk than other children for many acute and chronic conditions and death. They are 2 to 4 times more likely to die due to accidents and disease, 2 times more likely to get bacterial meningitis and rheumatic fever, 2 times more likely to develop anemia due to inadequate diets and lead poisoning from their environments. Moreover, they are 2 to 3 times at greater risk for problems associated with poor access to medical care, including delayed immunizations, complications of appendicitis, diabetic ketoacidosis, and complications of bacterial meningitis. Finally, they are much more likely to suffer limitations in their normal activities as a result of illness. Health conditions often reach more severe stages in poor children, and among the causes of this severity, inadequate access to continuous primary care is a major contributor. Among children with asthma, for example, poor children experience more days in bed each year and miss more days of school due to this condition than non-poor children, despite the fact that their rates of asthma are about the same, and poor children possibly may have lower rates of asthma. They are also more likely to be hospitalized for complications of their asthma, but they receive fewer physician visits, a difference that persists when controlling for the severity of their asthma. Poor children with asthma are much less likely to have a physician's office or HMO as their usual source of care, and far more likely to receive their care at a hospital or other institutional setting, where they are less likely to receive the continuity of care that is essential to effectively managing chronic conditions. Medicaid has improved access to care for poor children, but even those with Medicaid have poorer access indicators than non-poor children. Some of the most serious health problems of children, however, require interventions beyond access to primary care. Unintentional injuries cause more deaths among children than any other cause, and the disparity between poor and non-poor children is substantial. Deaths due to fire and motor vehicle accidents kill a greater proportion of poor children than non-poor children. And the homicide plague is concentrated in poor communities, although it spreads fear across cities and towns throughout this country. Among children under the age of 15, homicide kills African American children at 5 times the rate for white children. These health problems require broad social and public policy interventions to reduce injuries and violence and to reduce poverty, which is a major cause of these problems. But poverty is widespread among children, and it is growing. More than 16 million children are living below the poverty level today in the United States, including 6.6 million children under the age of 6. The 1993 poverty rate of 23%, nearly 1 in every 4 children, is up from 20% just 3 years before in 1990, and up from 18% in 1980 and 15% in 1970. Nearly 8 million more children live just above the poverty line. Altogether, a third of all American children live in families with incomes so low that they generate many of the adverse health consequences that we've been discussing this morning. Rates for Latino and African American children are several times higher, accounting for much of the racial differences in health status. The largest proportion of poor children are non-Latino white, but Latino and African American children have poverty rates 3 times higher than non-Latino white children. In 1993, 42% of Latino children were living in poverty and another 20% were near poor, altogether about 2/3. And 47% of African American children were poor and another 15% were near poor. The relationship between poverty and children's health, however, is not due simply to having a low income. Poverty is an indicator of a variety of conditions that limit a family's ability to provide the material, social, and psychological supports that children need to survive and develop to their potential. A recent study of Cleveland neighborhoods demonstrates the effects on children's health of poverty-level income and the social conditions associated with concentrations of poverty. The researchers found, not surprisingly, that the percent of neighborhood residents who were non-white and the percent whose incomes were below poverty significantly affected low birth weight rates in each neighborhood. However, when social indicators related to poverty were added to this statistical model, namely neighborhood crime rate, the percent of housing that was operated by the municipal housing authority, the percent of housing that was substandard, and the number of births to unwed mothers, race and poverty were no longer significant predictors. Their findings for infant mortality were similar. In other words, it was the social conditions bred by poverty and racism, rather than poverty and race per se, that predicted low birth weight and infant death rates. Although these concentrations of poverty generate adverse community-level conditions, poverty is also geographically dispersed. Inner-city poverty is in fact only a small proportion of total poverty in the United States. Although Latino, African American, and Asian Pacific Islander children are more likely than non-white Latino children to be poor, the increase in poverty is due to a number of factors that afflict families of any ethnic group in many parts of our cities and rural areas. Sarah Rosenbaum, one of the nation's leading child health analysts and advocates, estimates that 73% of the increase in child poverty rates between 1979 and 1987 is attributable to changes in the economy and the declining effectiveness of public policies and programs in helping families escape from poverty. The remaining 27% of the increase is due to a growing proportion of female-headed families. The decline of employment in manufacturing and other high-paying industries has dealt a serious blow to working families' abilities to support themselves. The growth in service sector jobs has not compensated for this loss. Between 1973 and 1990, the average weekly earnings of non-supervisory workers dropped by 19%. During the same period, the median hourly wage for men under 25 fell 29%, making it difficult, especially for young families, to provide for adequate food, decent housing, which is essential to family and community security, or other necessities. The poverty rate among young families nearly doubled between 1973 and 1987. accounting for half the growth in the number of poor children in the U.S. during this period. For families in the lower 20% of the income distribution, family incomes declined more than 4% in the 1980s. Full-time work, even for the full year, does not guarantee that a family will have adequate income. Among all children living in poverty in 1993, 36%, nearly 6 million children, lived in families with at least one full-time adult worker. Given these conditions for full-time working families, a two-parent family is almost essential to make American families economically viable. In 1993, 28% of all children lived in single-parent families, 49% of them, nearly 10 million children, living below the poverty line, and another 15%, nearly 3 million children, were near poor. Altogether, then, two-thirds endured deprivations of very low incomes. Children in single-parent families were 4 times more likely to live in poverty than children in two-parent families. The necessity of having 2 full-time breadwinners in a family is demonstrated by a U.S. General Accounting Office study of poverty among infants and toddlers under the age of 3. Among infants and toddlers whose families included 2 parents who both worked full-time, less than 1% lived in poverty. But for those infants and toddlers and families with only 1 full-time working parent, nearly 16% lived in poverty. Public policies have a demonstrable effect on family incomes and on children's health. Employer-provided health insurance has been declining for nearly 2 decades due to changing employment patterns, changes in employer practices, and changes in family structure. By 1990, 61% of children were covered by employer-provided health insurance, well below the proportion just a decade earlier. And Medicaid covered 18% of all children, a substantial increase in the same period. Medicaid's growth has been fueled by this decline in access to private health insurance and the growth in the number of poor children. Government stepped in to cover more pregnant women and young children because the need was growing, and the evidence that Medicaid improved access to care for pregnancy and for children was incontrovertible. Nevertheless, in 1990, 13% of American children were completely uninsured throughout the year, a figure that would have been closer to 31% if it were not for Medicaid. Despite the expansion of Medicaid, financial support for the non-working poor has fallen in the past 2 decades. Several major government programs that have been shown to improve access to health care, including community and migrant health centers, the National Health Service Corps, federally funded family planning clinics, and maternal and child health services, have been operating at much less than their 1980 real dollar funding levels. Funding for these and other health and family support programs are about to take another plunge if the new leadership in the Congress is successful in its agenda. The proposed cuts in health and social spending, including cuts in Medicaid, family financial assistance, disease prevention programs, housing assistance, and nutrition assistance programs such as WIC, the school lunch program, and food stamps, all of which have been shown to be extremely effective in aiding poor families and aiding children specifically, are disproportionately targeted in these budget cuts. The proposed termination of entitlements and the budget cuts in health and social spending amount to what many have come to call a war on America's children. We need to find ways to make public policy more effective in addressing the health and social needs of America's children, but ending entitlements and draconian cuts in spending clearly are not the answer. The costs of social programs are increasing because poverty and other social needs are growing. We must organize and mobilize ourselves as professionals, as students, as citizens, to protect and support these programs and the children they serve. The American Public Health Association has long been working with organizations and coalitions of health professionals and advocates to mobilize support for these programs and services. and we join with our colleagues in medicine and law in this effort. We have the means to save our children, and we can save them if we have the will. America's children deserve our serious commitment to their health and development. Thank you.
Good morning. My name is Eric Colon, and I'm a first-year medical student at the University of Massachusetts Medical School in Worcester. This is a great symposium that we're talking about because, sorry, I'm nervous a little bit. Throughout my whole life, I've seen violence, poverty. I was born and raised in New York area, New Jersey. I went to grammar school in El Barrio in New York City. My family's always been on the run from violence. Every time something happened in school, my parents are fortunate enough to be able to move to a different district, a different area, and put us into a new school. I have many family and friends who have died from guns and are unable to leave the inner cities because of their financial situations. One thing that I've seen throughout my family and friends is that their goals in life have changed. They no longer try to succeed in life, but now they're trying to survive life. And that's a problem I hope we can all solve in the future. Philip Johnson, a former Massachusetts legislator and cabinet member with a strong background in both state and national issues and legislation, was sworn in on December 9, 1993, as the Regional Director of the United States Department of Health and Human Services. Prior to his appointment, he served as Director of Robert F. Kennedy Memorial in Washington, D.C., an institution which has been involved with social justice and human rights issues for more than 20 years. Before his service in Washington, Mr. Johnson was Secretary of Human Services in the Commonwealth of Massachusetts from 1984 to 1991. As such, he was Chief Executive Officer and Principal Policymaker for 17 diverse and sensitive state human services agencies, including public health, juvenile corrections, and public welfare. It gives me great pleasure to introduce Philip Johnson.
Thank you, Eric. It's a pleasure to be here at my old school. I'm an alumnus of the John F. Kennedy School of Government. Though when I was here, I'm so old now. I'm feeling so old. It was before there was a building. Well, there was a building, but it wasn't this building. It was over in Harvard Yard, and it was called Litauer. And my wife came here, I think, the year after this building was built, and as good a time as I had over at Litauer in the Yard, she had an even better time here because of the fact that everybody's kind of together here. And I think the experience that students have now as a result of this terrific institution is really wonderful. For those of you who have noticed my tie, you can feel free to put on your sunglasses. This is a Head Start tie. I thought it would be appropriate to wear that this morning since we're talking about kids. Head Start being probably the most successful and effective and important program that's operated by my agency, the U.S. Department of Health and Human Services. Should just before I begin borrow from my old professor and one of my great heroes from Harvard, Ken Galbraith, always likes to begin his talks by warning people that at the end of them you may not be any wiser, but you'll be a good deal older. And I'll try my best, although I suffer from the same tendency that Ken Galbraith does to carry on a bit. I'll try very hard to not do that today, particularly since we're running right on schedule, as I note. And let me just say that I guess my responsibility this morning is to, in a little less formal way than the other three speakers, talk about some of what's going on in Washington, give you a flavor for the politics as they relate to children and to families. I don't want to give you a partisan speech, but I come from a personal background, which is you could detect, I'm sure, in listening to Eric's introduction, I come to this discussion with a set of personal beliefs that are very strong. What he didn't mention is that I began my career as a child welfare social worker in the 1960s, right out of college. So for several years I carried a caseload of 75 abused and neglected children. And the experience that I had as a social worker, much more than any experience I've had since then in politics or in government as a policymaker, helped to shape the views that I have about kids and about families and about poor people, and I guess more broadly, more generally about our society. And I guess that I have to begin by reminding us all that we come to the discussion this morning in a political context in which we have a band of people leading the United States Congress in Washington who believe not only in repealing the New Deal, although they do believe in that, but they also believe in going back to the Articles of Confederation. You remember them? Back in the 1780s. We recall how well that all worked when there were 13 states. Now there are 50. We have our United States House of Representatives led by a man who has proposed seriously that children of poor women be placed in orphanages simply because they are children of poor women. We have a situation, as Dick pointed out, in Washington in which all the programs affecting the elderly, Social Security, Medicare, have been taken off the table by these same people, largely because of the political heat that they will experience because of the fact that the elderly are well organized and they vote. I'm not suggesting for a moment that it would be a good idea to cut services and programs for the elderly, I hasten to point out, but the fact is that that leaves women, immigrants, public employees, and particularly children on the chopping block. And as the President said at his press conference yesterday, there is a deliberate policy on the part of the leadership in the Congress, which is pretty obvious from reading the newspaper, watching the television these days, to cut services and programs, financial assistance to the poorest children in the country, and use the savings from those cuts to finance a tax break, a tax cut for the wealthiest citizens in our country using the capital gains tax mechanism. I believe that's reprehensible. If we need to make cuts in the federal budget, they ought to be done in a sensitive way that takes first from the rich and not first from the poor. This is Robin Hood in reverse that we're seeing in Washington these days. But I want to talk about two particular issues. One, juvenile justice, a little different twist on the issue of violence. And second, I want to talk a little bit more about the issue of foster care and child abuse, and then give you a sense of where the Clinton administration is drawing the line in the sand on some of these very, very important issues. I want to begin by telling you two quick stories. I was running the Robert F. Kennedy Memorial Foundation in Washington during my 3 or 4 years out of the government. I had been working in state government and for Michael Dukakis, and left and went down to Washington to run the RFK Memorial, which was a great honor and a lot of fun. It happened to coincide with the 25th anniversary of the death of Robert Kennedy, which was on June 6, 1993. And on that date, we had a mass, an anniversary mass at Arlington National Cemetery at his gravesite. The President spoke. It was a very moving occasion. For any of you who saw it, there were 20,000 people who showed up. But the next morning, there was on the front page of the Washington Post, there was a big story about the mass. And right below that story, there was another story about a 13-year-old African-American boy who had lived in Washington, D.C., had been a very successful student, up until that point, had come from a solid family where there was a great deal of support, single-parent family, but great deal of support from his mother and from his older siblings. And about 6 months earlier, he had gone on a joyride in an automobile with another friend and was picked up by the police. And as a consequence of that, although he had had no previous record, he was put into one of the two juvenile correctional facilities in Washington, D.C., which I should point out has by far the highest incarceration rate in America. And while he was there for what was essentially an indeterminate sentence, he got into a beef with some other kids. After about 6 months, he was released. He was released the day before our Mass at Arlington National Cemetery, and that night he was walking down the street, and one of the kids with whom he had gotten into the beef within the institution did a drive-by on the 13-year-old and murdered him. And when I read the story about what had happened to this 13-year-old boy, I said, gee, that story really sums up the way in which we deal with juvenile offenders too often here in the United States. We commissioned a study by the National Council on Crime and Delinquency, which is one of the more important criminal justice reform organizations in the country, go in and take a look at the Washington, D.C. system. They came back and they found some very interesting facts. First, that 25% of kids who were incarcerated in the two big institutions, where I should point out they today use manacles, leg manacles, and leg irons on the kids to move them within the wall, within this big perimeter wall within the institution. 25% of the kids were first-time nonviolent offenders, like this 13-year-old kid. Fully 50% of the kids in that facility had never committed a violent crime. The other 50% were older kids who had been incarcerated in that system for very heavy offenses. And so what they're doing in Washington, D.C. is taking 12-year-olds and 13-year-olds and 14-year-olds who have not been in trouble with the law before and throwing them in with older, very tough, violent offenders. And so it doesn't take the National, or it shouldn't take, the National Council on Crime and Delinquency to figure out that this is not a wise policy. And that's the reason why in many states in our country we have recidivism rates that are in excess of 70%. You go through one of these facilities as a 13 or 14-year-old, and you get angry and hostile and resentful and bitter, and you come out and you start shooting up your neighborhood. And it is very easy to predict early on who's going to do this, who's going to be creating that kind of violence for that reason. The second story I wanted to tell is about a friend of mine, and the reason I use her name is because she wrote about herself in the Boston Globe a few weeks ago. Meg Valancourt used to be a reporter with Channel 2 here, as I say, is now a reporter for the Boston Globe. And I've known her for years. She used to cover me in Human Services when I was in state government. And I knew that she had been a Rhodes Scholar. I knew she had been one of the top students in her graduating class at one of the best colleges in the country. And I just sort of assumed that she had had this upper middle class upbringing in some affluent suburban community, and that things had just been great for her from the day she was born. I never asked her really what her personal background was. She married a friend of mine who was in our cabinet in the Dukakis administration. She wrote this powerful story in the Globe, which some of you might have seen a few weeks ago, after Newt Gingrich's comments on orphanages. Turns out that she had been a victim of domestic violence, victim of child abuse in her early life. She and her siblings had been removed from their natural parents, had been placed in foster care. She like many foster children, went from foster home to foster home to foster home. Sometimes she was with some of her siblings, other times she was not. So they were split up at different times as well. And she had a very, very hard time, as did her siblings. And in fact, in one lengthy placement, she was routinely abused, sexually abused by the foster father. When she became about 12 years old, she was placed in a home where the parents, the foster parents, just took a great interest in her and supported her and kept her there through her adolescent years. And as I pointed out earlier, she then went on to make it in the society. And she wrote what had happened to her in very spare, almost Hemingway-esque language, without any emoting. And yet the impact of reading this was as powerful as anything I've read about what it's like to be a foster child, what it's like to be the victim of child abuse and be placed among strangers as a consequence of being victimized by adults. And I talked to her about this privately afterwards, and she said, you know, I made it, but my siblings really didn't. It's not that they're not alive. They are alive. They're functioning, sort of. But she said as adults, they've had it very, very tough. And she said, you know, I'm really one in a million who made it through that system and succeeded. And I guess that the lesson that I learned from that, and it's a lesson that I learned from being a social worker, is the importance of one caring adult in the lives of children who suffer. And certainly in Meg's case, that was true. And anybody who's ever worked with kids who are in trouble will tell you that the impact that we have as adults on individual children is just much more powerful than any of us realize. So I don't know what the role is in the end of the government. I think we all are mystified by what causes violence within families, what causes particularly members of my gender to strike women and children and to hurt them. I suspect that a lot of it has to do with substance abuse, and I guess most of the research would suggest that that's the case. I do not believe that domestic violence is restricted to poor people. Poor people get picked up more often than middle-class people because there are social workers and police going through their homes more often. But I grew up in an affluent suburban community, and I could recite for you, as I'm sure many people in this room could, with their own backgrounds perhaps, tell of tales of domestic violence that took place in very middle-class households in suburban communities. So it's going on out there. Kids are suffering, and too often than not, they are not detected by the system. So I want to give you some sense as to where our agency and the Clinton administration not only stands, but hopes to move the system that has been built up in this country, both around juvenile corrections and around the issue of child welfare and foster care. In Massachusetts, for about 20 years, we've had a system of dealing with juvenile offenders that I think has been viewed as a national model. And it's a very simple system. It recognizes the fact that there are differences among children who break the law and are picked up by the police, and that you cannot use and should not use a cookie-cutter approach to the issue of juvenile corrections. And so what we developed in Massachusetts 20 years ago and have strengthened, at least until the last 2 or 3 years, was, I say parenthetically, I wouldn't be too mean about this, is a system which, in which children can move along a continuum ranging from staying at home with the natural parents. If you have a situation such as the one I described with a 13-year-old who's doing pretty well in school, comes from a good, strong family, going to get a lot of support, has not committed any particularly serious offense, but at least to support that family and watch and monitor the situation, ranging to group homes in the community where perhaps the offense has been somewhat more serious, all the way to secure treatment centers for violent offenders. And I ran an agency for a long time which handled about 1/3 of the violent juveniles in the state. The recidivism rate was lower than any other state in the country. And I might add the per capita cost here of dealing with kids in this way is lower than the per capita cost of any other juvenile correction system in the country. Pretty good outcomes for anyone who's interested in reducing the level of violence in the society. We recognize the fact as well that there is this very direct connection, as the other speakers have pointed out, between child abuse, domestic violence generally, victimization as a child within a family, and then acting out in the community in a violent way. 70% of the children who go through our state's Department of Youth Services, which is our juvenile justice agency, had some involvement with the State Department of Social Services, which is our foster care agency. And as one who was at one time responsible for adult corrections here as well, I can tell you that you can go into any prison in this country and you will find, studies differ, but somewhere between 70 and 90% of adults who are incarcerated throughout the United States were victims of abuse themselves as children. So this cycle of violence, this escalates as the child ages. And so it makes sense, it seems to me, to intervene early, the first sign of trouble within a family, move supportive services into that family, and try to the extent that we can to keep the family from breaking down. Because I will tell you, as Meg Valancourt's story suggests, for most children, once that child is separated from his or her natural parents, for whatever the reason, that child has suffered a trauma that is going to stay with him or her for the rest of their lives. And the likelihood is that that person will show up again later on in a human services or a criminal justice program, either in a juvenile corrections, in the juvenile correction system, or in adult corrections or adult mental health. And that's the reason why our administration and the Congress, at least the previous Congress, strongly supported what's called a Family Preservation Program, which is to do precisely that, to move services into these troubled families early on and provide them with crisis management and supportive services in order to keep them together so the children don't leave the families and have to be placed into foster care and then begin that cycle that is so destructive. But the President has drawn and will continue to draw the line in the sand around a whole range of other issues as well. Dick pointed out very correctly that the Medicaid program and all of the child health initiatives that have been so crucial to poor children during the last generation or more, we've got to try to maintain. If one looks at what the Republicans are doing, as I pointed out before, virtually everything else is off the table. They've taken taxes off the table, defense is off the table, Social Security is off the table, Medicare is off the table. What's left? Medicaid, and I suggest they're going to retreat a little bit on Medicaid when they discover the fact that 70% of the Medicaid dollars go to the elderly because of support for nursing homes. but 30% or so of those dollars go to poor children and poor women. And I would dare say that those are on the chopping block. Child nutrition programs, which are so crucially important. You pointed out low birth, to try to deal with the low birth weight, to make sure that all of our children are immunized. We have an obscenely low immunization rate here, to the point where a few weeks ago the Agency for International Development actually sponsored a conference here in Boston, to which they brought public health experts from third world nations to come here to instruct our people how to immunize our children more effectively. Welfare reform, the demonization of poor women continues. The demagoguery from the right on this issue has been nothing short of reprehensible, not only at the federal level, but at the state level, within the states as well. The assumption being that women on AFDC don't want to work, that you have to somehow club them into submission, you have to force them, you have to threaten them with termination of benefits in order to get them to work. Whereas our experience here in the 1980s with the Employment Training Choices Program, affectionately known as ET, remains the single most effective and successful welfare reform program in the history of the country. Why? Because we assumed, correctly it turned out, that poor women don't like being on the welfare rolls, and that given a little support and a little help, they'll flock to jobs. What are the supports? What is the help? Child care, good, affordable child care, transportation, health care, job training. And so the President's bill, and one hopes the bill which would wend its way through the Congress would contain those features and would retain as well the entitlement for poor children to have some support for the basics of human life, and that entitlement is not eliminated by the Congress. Substance abuse prevention and treatment. If I were king for a day, I would put a lot of the nation's wealth into substance abuse prevention and treatment. The longer I'm in this business, the more I believe that a lot of what ails us relates very directly to alcohol and drugs. That's certainly true when we talk about violence. As I pointed out before, the Centers for Disease Control did a recent study showing that if you have a gun in your possession, you're 16 times more likely to use it if you're under the influence of alcohol. Makes sense. Why don't we take this issue seriously? Why aren't we addressing it more effectively, both at the local level, the state level, and the national level? Our agency is working very, very hard with the states and with nonprofits and with the health community to reduce substance abuse in the society. The Head Start program, as I proudly pointed out before, not only is successful, but I think the American people know it's successful. It's aptly and beautifully named to give kids literally a head start in life. And for those kids who are poor and come from families in trouble, families in chaos, that Head Start experience can make all the difference. Protective services to children who are victims of abuse and neglect, where the federal government through our agency provides hundreds of millions of dollars to the states to deal with the increase in caseloads of child abuse and neglect at the state level. The leadership in the Congress now is trying to cut those funds significantly so that there would be, for instance, in this state, a $10 million cut as a result of the contract with America. This at a time, I would remind you, where the numbers have never been higher. When I was a social worker, and for many years after that, there were always about 10,000 children in the care of the Department of Social Services here in Massachusetts. Guess what the number is today? About 60,000. A lot of that has to do with crack cocaine. A lot of it has to do with the increase in domestic violence. When I was a worker, there was virtually no incidence of guns being in households. Today, if you're a social worker, frequently, if you're going into a public housing project to deal with some of the cases, you have to bring a cop with you. So the states find themselves under increasing pressure to deal with these extraordinarily serious cases, but also the numbers themselves, the real numbers have skyrocketed. And so to cut those would seem to me to be very, very foolhardy. And then finally, and I think extremely importantly, the prevention money in the crime bill. Not only is the leadership in the Congress attempting to take the 100,000 police officers who were part of the bill that passed last year and turn that money over to the local communities to do whatever they wish, whether it be cops or something else. But they also have been trashing the notion that prevention works. I don't know about you, but I think midnight basketball is a pretty good idea. I mean, Ray Flynn, who, our former mayor here, happened to have a gift working with adolescent kids, in large part because he was a great basketball star at Providence College. I used to see him out there at midnight and sometimes later, some of the streets of Dorchester and West Roxbury and Mattapan, playing basketball with kids. And some of these kids were pretty tough. And if they hadn't been playing basketball, I don't know what they would have been doing. And so for politicians in Washington to just blithely say, well, let's do away with all this because it doesn't make any sense, I should say parenthetically, by the way, though it deserves underscoring, it isn't just midnight basketball, it's also substance abuse prevention and treatment money and mental health treatment money and a whole range of other very directly health-related issues are part of that crime bill as well. I hope that we can develop a bipartisan consensus around the importance of what was in that bill, and I hope that it will not be eliminated. I can tell you from working here in the 6 New England states very closely with not only the health and human services professionals, but also with law enforcement officials, that the law enforcement community needs to have those tools in order to deal with the issue of violence, whether it be violence within households or violence out on the streets. Well, let me just conclude by using a quote that Robert Kennedy used to like to use when he was running in 1968, and he used to like to quote Camus, who wrote, "Perhaps we cannot make this a world in which children are not tortured, but we can reduce the number of tortured children. And if we won't help, who will?" In the Meg Valancourt story, I told you that the lesson for me was the importance of one caring adult. And I think in the Robert Kennedy quote, what he was trying to say to us was that when we talk about children who are being tortured in our society, not only does the government representing all of us have a responsibility. Not only do these very important national organizations, which are represented here at this table, have a responsibility. Not only do institutions like Harvard University have a responsibility, but more importantly, each of us in our daily lives has a responsibility to reach out to those children and to do everything we can to provide them with protection and with love. Thanks very, very much.
Thank you, everyone, for participating in today's event. I'm honored to give a few closing words. By way of introduction, I'm Alexander Fix, a second-year medical student at Harvard Medical School and a representative to both the Massachusetts Medical Society and the American Medical Association. Our guests this morning have highlighted the need for intervention to combat poverty and domestic violence. I hope that all of us will consider how we, in our careers, whatever they may be, can promote these goals. And just to add a little bit from my own background, I'm someone who came from also a relatively affluent suburb and a relatively sheltered life. And I think for people like me, who are found in significant numbers in the professions, the importance becomes not just, we have to go one step further. We, who may have been sheltered from some of the problems, though they are prevalent in all communities, need to get ourselves to learn more about them and to meet people and to just make a real effort to familiarize ourselves with them so we can build on that and then make our interventions and our efforts more effective. In a few moments, we'll have a 10-minute break. We'll begin following the break with the signing of a consensus document illustrating the unanimity of the AMA, ABA, and APHA on children's issues, an unprecedented occurrence. A discussion moderated by Professor Mark Roberts will follow. Please bring your questions. I look forward to seeing you back here in 10 minutes. Thank you.
Hello, my name is Gail Blanchard, and I'm a second-year medical student at Boston University. And I was the chairman of the policy committee that created a document which put side by side the common policies of the ABA, AMA, and the American Public Health Association. I'd like to introduce the signing of this document for all three of these great organizations. Thank you.
Are there ceremonial pens?
Yeah. Well, we have to give her ours.
I have marvelous penmanship for a physician. I want you to know that.
I think that's right. Are you a real doctor?
My wife would love to hear you say that. What are you going to do? Oh, very nice.
Hi, my name is Derek Kunimoto, and I'm a second-year medical student, first-year medical student at Harvard. I'm getting a bit ahead of myself here.
That's what you think.
I would like to introduce Mark Roberts. Dr. Mark Roberts is a professor of political economy and health policy and a member of the faculty of both the Harvard School of Public Health and the John F. Kennedy School of Government. A former chairman of the Department of Health Policy and Management at the School of Public Health, he now serves as a faculty chairman of the Kennedy School's Executive Program for Senior Managers in State and Local Government. Professor Roberts is the author of more than 40 professional articles, and he has written widely on public policy problems with a focus on environmental regulation and the organization of healthcare services. We are privileged to have him as our moderator.
It always bothers me when I listen to a talk show and the callers call in and compliment the talk show host on what a great show it is. It seems to me a little obsequious, but I'm afraid I have to compliment the organizing committee on having produced such a stellar panel of people this morning. And because they are so interesting, I want to suggest a few ground rules for the question and answer session. The main ground rule is we're here to listen to them primarily, and therefore we'd like to ask you to restrict yourselves to relatively short questions. Statements of principle, political debates, and expressions of your view about the existential circumstances are really not what we're after this morning. we're here to listen to them. We have two microphones. I'll go from mic to mic alternately. I will feel free to cut you off if I feel you are making a political statement, so I offer that. But there is no reason why, because you're asking questions, you have to be deferential and polite. And people are more than welcome to go to the microphones now. And while people are going to prove that we don't have to be deferential and polite, I'll ask the first question in a non-deferential and impolite way. And I'd like to ask particularly Bob McAfee and Roberta Cooper-Ramo. It is interesting in the document that you both just signed, which was characterized as a consensus document, that there are some interesting differences among the positions of the various groups. And I was particularly struck about the difference between the American Public Health Association and the American Bar and American Medical Association's announced positions on handgun control. And I understand that as leaders of professional organizations with a diverse political constituency, it is necessary for people to balance those conflicting interests. But since the APHA specifically endorses and supports legislation prohibiting the manufacture, sale, transfer, or possession of handguns and handgun ammunition for private use, as a member of the APHA, we all know that the APHA is a bunch of lefties, as demonstrated by that. But I wonder, Robert and Roberta, if you would, and in the process, comment on the problems of leading a large and diverse organization through the very complicated political shoals of contentious issues like this.
Let me begin, Mark, and I do point out that I do represent a membership organization of 300,000 physicians scattered all over this country. And to much of our membership, not to much, to some of our membership, particularly those who live west of the Mississippi River, that gun control means a steady aim. And on the other hand, I'm very proud that an incremental, almost annual update in our gun control policy has happened over the last 3 or 4 years. Right now, it is the policy of the AMA that there should continue to be a ban on assault weapons, and we will continue to testify for that if the crime bill is revisited in that aspect. That we feel that, and we passed a policy in December at our meeting, that the Saturday night specials, which are the cheap, inexpensive guns, probably responsible for almost 80% of the homicides caused by handguns in this country, should be outlawed in this country. I personally took part in a gun control conference in Los Angeles, the Circle of Fire conference that was sponsored by California Medical as well as California Wellness and the Physicians for Social Responsibility, pointing out that the 6 manufacturing companies, all within 20 miles of downtown LA, all interrelated to the Jennings firearm family, even though they all have different names, are responsible for about 80% of the production of those guns in this country. A gun that would not be legally imported because it is not 4 inches at the handle and 6 inches at the barrel. Each of those 6 guns which I held in my hand can be covered by my hand. You could not see that pistol. It is not a pistol because it doesn't meet those regulations, but I can cover it with my hand. We have also taken strong positions, even though we have 200 million guns in this country and will be with us for 100 years, we only have a 4-year supply of bullets. And we have testified on several occasions to outlawing and demanding and have been successful in getting the Winchester Company to withdraw the Black Talon hollow point bullet from the marketplace. The bullet which is, when it strikes and tears into human flesh, causes the tremendous small tiny fragments which remain a hazard to surgeons, to operating nurses and other personnel who have to debride these wounds. I think that we're getting there when it comes to gun control. American Academy of Pediatrics, one of our constituent members, always has a bill, has adopted a policy, complete outlaw of handguns. We have 2 members of our 400-member House of Delegates who are gun dealers. So I point out to you we have an interesting panorama of people in our community. I, as one who lives in Maine, who hunts, who has a shotgun and a .30-30, I can understand that constituency who supports that for sporting purposes. And I understand, although I don't have a handgun, that there are some sporting kinds of pistols that have some sport associated with them. I fail, however, to see the majority need to protect ownership of handguns by particularly individuals who have criminal records, etc. And I think the Brady bill, which I hope does not come up for, not the bill, the Brady law, does not come up for revisiting. We intend to testify against that if that so happens. There has been a good track record to date. What did I see that 57,000 applications had been denied across this country because of people who had either felony convictions or other reasons to deny them the permit. I think there is a responsible way to look at guns, and I think we've sat down, surprisingly, with the National Rifle Association on 2 occasions and have said, you know, guns are not like automobiles. An automobile is terribly necessary in our society, but can be a lethal weapon. We've overcome the lethality by insisting you be of a certain age, have taken a course in automobile safety, demonstrated your proficiency, and must live up to the credos of licensure for a lifetime in order to have the privilege of driving an automobile. At the same time, we've assured that the automobile is safe, it's registered, we know where it is at all times, that it must be annually updated to be sure it's safety for the driver and for others on the road. Why can't we do the same with guns? Why can't we say that you must be of a certain age to own a firearm, have taken the National Rifle Association Safe and Responsible Gun Safety course, demonstrate your proficiency, know how to store and keep that gun away from those who don't have that knowledge, and then be assessed periodically and evaluated on your ability to live up to that standard. At the same time, you have every gun registered, know where it is at all times, and guns found that are not registered can be confiscated and destroyed. Well, NRA is still scratching their head over whether that's a good deal or not. Obviously, they're concerned about any intrusion that might extend to anything else. But I'll tell you that I think we're getting there. I think our policies now on guns are a good deal more restrictive than they were 10 years ago. And I'm hopeful that we can approach the more restrictive policies that some of our member societies have, hopefully within the next 10 years.
Mark, actually the ABA's position is not all that much different truly from the AMA's position on gun control. I think that at least twice in the last 2 years among the 4 ABA meetings there have been in front of our House of Delegates policies that deal with issues of gun violence, and in each case they've been passed by the House, a House which represents 370,000 American lawyers of at probably 400,000 different political views. I think additionally we're looking in a very serious way about how you deal with the problems of crimes committed where there are guns present with children, by children, and additionally looking at the kind of responsibility that parents have when their children show up with guns in a variety of situations. Across the country, I don't want to say this is an epidemic because it is not, but we all know of even children of police officers who've ended up at school or in their neighborhoods with the guns of their mother or father in their hands, sometimes fortunately damaged unto no one and sometimes tragically damaged done to many. But that gives you, I think, some sense of the danger that handguns, even when the adult that has them is a responsible person. I think the other part that we have to talk about in a very important way is the whole idea of where violence is in the hierarchy of American culture, because the gun violence that is done in some measure because violence is a part of our culture that's simply been acceptable. And I think lawyers and what we do every day is the absolute antithesis of that kind of violence. What we're about is trying to help people solve even their most passionate problems through accommodation and conversation, and so you could not find an organization more dedicated to the opposite of gun violence than we are.
Thank you very much.
As a school teacher and public health student, I'd be curious if the panel could address the following as prevention strategies for violence. Comparable pay for women so that they can have the resources to leave their battering partners, a living minimum wage to support parental self-respect and self-reliance, and a policy of full employment so that all families have a chance to succeed and we can reduce the need for welfare. And finally, could the next consensus include people from the School of Business across the river?
Richard, do you want to start? Mr. Brown?
Sure.
Full employment, equal pay for women, and minimum wage.
And full employment, right. And I think these are essential public policy tools to assure that a working family has adequate resources to support itself, not in luxury, but simply with the necessities of life. One of the main factors in the increase in poverty, as we have discussed, is the increase in the number of female-headed households, single-parent households. And the problem in those households is that those women have no incentives to leave welfare and go to work, because if they do so, their standard of living will fall below the exceedingly low level that welfare provides. These are women, typically, most of them, who do not have either the work history or the educational preparation to get jobs that pay an adequate and living wage for their families. So that I think that raising the minimum wage would help them, and it would also assist two-parent families where both people are working and yet the family remains below the poverty level, to also have adequate resources to provide for the family and for the children. So I think issues of comparable worth are very important to sustaining the kinds of conditions in a family and in a community that children need to develop and to thrive and even to survive, that women need to gain a measure of independence. I also think that the issue of full employment is one that we often overlook as a public health issue. I actually believe that the Federal Reserve Bank probably has a larger impact on the health of people in this country than perhaps any other policy making body that exists in this country. The Federal Reserve Bank attempts to manipulate the unemployment rate by using the interest rates to prevent the unemployment rate from falling below 6%. That is designed to control the rate of inflation. But in doing so, they are first of all dooming a small but significant part of our population to permanent unemployment. And furthermore, by maintaining that level of unemployment, they are making it more difficult for people in the bottom rungs to negotiate with employers to gain higher wages that become a living wage. I think all of these are public policies that are really critical to addressing the kinds of problems we've talked about today. Violence in general in our society, the absence of a legitimate economy in many inner city communities, the conditions under which women increasingly have to raise children, the conditions under which children grow up.
Thank you. Would any of our other panelists feel compelled to add something? I know Phil will, but before let's let Phil have a shot because he hasn't talked yet.
Just briefly, every study that's been done on child abuse that I'm aware of shows that the single most important factor is economic stress, even though, as I mentioned in my remarks, I think substance abuse is obviously extremely important as well. I remember when I was in state government looking at the DSS numbers in the Quincy and Weymouth DSS offices when the Quincy shipyard was shut down, and the protective cases skyrocketed in the months immediately after the closing of that shipyard. It isn't just simply full employment for women, it's full employment for women is very important. Full employment policy generally is extremely important because the shipyard, certainly there were a lot of men who were laid off, and the frustration and the anger is acted out in the home. And so I think Dick's absolutely right to the extent that we can view public health more broadly to include issues like that affect the economy, so much the better.
Two comments. In Albuquerque, we've had what was a really model program for a long time, which was a school called the New Future School, which was a high school for pregnant teenagers. And one important part of the problem that we haven't spent much time talking about today is this problem of early adolescent and adolescent mothers of children. What was so remarkable as they did some of the studies in that school was that they found that as they began to give the young women attending that high school two kinds of supports, Remarkably, they did not have a second child out of wedlock. And the two kinds of supports were, first of all, serious teaching about how to be a parent, what it meant to nurture, something that many of these young women had simply never seen in their lives and had literally no idea about what that meant other than actually having the child. And the second part that was equally important, either one alone I think would not have had the same result, was that they trained and sent these young women in high school with children out in part-time jobs. The kind of self-worth that they felt when they actually were out working in an office, seeing that they could be responsible not just for their child but for themselves in a working environment, gave them a kind of self-esteem that quite amazingly led almost uniformly to them not having a second child out of wedlock. Somehow in our society we've got the idea that that again is a kind of fuzzy-headed liberal kind of thing and we shouldn't help people in that fashion. And I encourage all of you to try to reject that thinking. It seems to me to be the most conservative economic strategy that we have in dealing with this problem. A second point that I wanted to make deals with spouse abuse. I think people need to understand that among the reasons that women don't leave relationships that are abusive is indeed the fact often that they're not employed, or it's difficult for them to be employed, or that money is out of their control. But you need also, especially as physicians, to understand, particularly as you go out into the practice world. I met an emergency room physician who was here earlier, that the most dangerous time for women is when they actually have the courage to leave that relationship. And as physicians, you need to understand and help them get the kind of help and protection they need to make sure that when they have that moment of courage, at which they leave, sometimes unable to take their children and often in the middle of the night with their children, that in fact their lives and their children's lives are extremely much in danger there. And so it's not just the lack of a job, it's an actual fear of what's going to happen often to their own children that causes them to do things. The last point I wanted to make was just in defense of the business school that's not here today a little bit. I think that business in America is beginning to understand that we can't have a nation of walled communities, and that when the children of our nation and the poor of our nation have absolutely no hope, American business doesn't have a hope either. I think you're quite right that we need to join them more often in our conversation. But I really believe, based on my own experience in speaking with general counsels of major American corporations, that there is a kind of understanding that we're all in this together that didn't really exist before. Unfortunately, it is also important to say, and fair to say, that we have a situation in which the welfare system hasn't worked. It just hasn't worked the way it is. And we can't go back to the old solutions and the old shibboleths and the old conversation about it, because we all know it hasn't worked. You just have to look at the results. And so I think it's inappropriate for us to be so quick to criticize the people who criticize the old results. We have to be ready, willing, and able to come up with new solutions.
I want to compliment you on this lively discussion, and I wanted to ask, there was only about one person, Loretta Ramo, that discussed the improving society by encouraging the character development in children. I just was hoping that maybe some of you all could speak to that. It seems that there is a trend in the nation, and just Time magazine this past week, on encouraging marriage, commitment, and what do you do about fatherlessness. And then just one other point about children. You do want to keep them in the home, yet when they do have an illegitimate child, that's when they're given money to go outside the home. So could you speak to perhaps your solution of keeping them in the home also, if you want to keep the younger children in the home?
Okay, character development and family preservation. Who would like to go first? Bob?
Let me just make one comment, because I cut this out of the Portland paper the other day in Maine, and this is a small editorial. It was prompted by two studies that have indicated in two communities in Greater Portland, the Cape Elizabeth, which is probably our most affluent suburban community, and Scarborough, which is probably the second, revealed through high school senior studies, and half of the high school seniors acknowledge being drunk in the last year. Many are intimately familiar with marijuana and other legal drugs beginning at age 12, etc. It goes on and on and on. But the comment that came from one of our very respected, at least one I respect, educators in our state, founder of the Hyde School. Many of you may know the Hyde School up in the Bath area. He calls for a major change in child-rearing attitudes. Depend more, he advises, on parental involvement, appreciation, and teaching by example than on parental expectations of achievement, which has become awfully prevalent in our society. And his quote I thought was good, is, "Our children are not us. Their accomplishments were not meant to be part of our trophy cases." I think that's a very prophetic statement that I would share with you, because I think many of us as parents have been terribly proud of those accomplishments and benchmarks as we go down the road. Benchmarks of excellence, of good behavior, etc., and have been unwilling to accept benchmarks of bad behavior, namely pregnancy, namely illegal activity which confronts the law for the first time, etc. And I think getting back to the basic hallmarks, as he has stated, on appreciation and teaching by example and parental involvement, for the better, for the worse, on those occasions, is probably a time for us to redirect our activities. I'm not an expert in, I'm not an obstetrician. I don't take care of pregnant women, and I can't give you what I think may be the solution to this problem, although I see societies trying to struggle with this. I see communities trying to struggle with. We finally passed a sexually transmitted disease clinic and free condoms in our two major high schools in Portland the other night by the school committee, an item that's been discussed for 3 or 4 years by our school committee, and that particular hearing was dominated by students participating in that discussion 2 or 3 nights ago in the Portland area. Maybe others have some response they'd like to make.
I'd like to make 3 comments. One, I think that this is a very critical issue, actually, in our society. But I think we're not very clear as a society. We certainly have no consensus as to how to help children develop character and a belief in something beyond themselves and their immediate gain, their involvement with family, with friends, with society. But I do believe that the modeling by parents is perhaps the most critical factor, and then the modeling by other adults in the lives of children. When children watch television, as they do much of the day, they're seeing modeling of behavior which is rewarded in television programs and in the movies, that is violent behavior, that is abusive behavior toward women, that is abusive and violent toward other individuals in society, and people who get by and get ahead on the basis of their greed and their selfishness. When children see this day in and day out and see relatively few other examples, alternatives to that, as modeling behavior, I think that communicates a great deal to them about what society's values are and what society expects. I think that modeling is much more important than any exhortations that we provide to our children or to our students, that preaching at them is not the solution, that it has an emptiness and an inauthenticity when our own behavior is not consistent with those exhortations. Secondly, I think we need to help young parents develop parenting skills. I think that's very important. Teaching them how to be parents, teaching them that being a parent does not mean either being a friend of their child, but rather being a parent, or simply letting the kid do whatever the child wants because you don't want to be bothered, that you have some responsibilities toward that child. Third, and the final point, is that I think we need to provide economic security to families in order to assist them in staying together, providing the kind of supportive environment that children need to develop their own character. One of the prime factors in the breakup of families, in the creation of female-headed households, is in fact the inability of many young males in this society who are not well educated to earn an adequate living. And when those families suffer chronic unemployment or very low incomes, the men lose any real significant role in that family. They become almost irrelevant to the family composition. And in fact, they become an economic drag on the family, and they do the family a favor, in effect, by leaving the family and allowing the family to obtain welfare. I think those are terrible conditions that we impose on families, and I think some of the economic policies suggested before and the kinds of social supports that we've talked about are important elements of helping families.
Roberta?
You know, we live in a crazy kind of world. Last night after we had a wonderful dinner, I turned on the television set and saw that featured was something called Powerball. I think I've said it right. I only saw it once, and it was a $100 million lottery. Government-sponsored advertising telling everybody that you could win $100 million by doing nothing except picking the right numbers. And I think for a whole variety of complicated reasons that have to do with the Vietnam War and racism in the country and things we don't have time to talk about now, we reached a point where we tore down a lot of institutions in the country which deserved to be torn down, and didn't recognize that we had to build up at the same time the institutions that were great American institutions, including the family, including respect for law and order, and including, most importantly of all, what was an almost uniquely American kind of characteristic that we were so proud of, and that was personal responsibility and a can-do attitude. We Americans could, with the dint of our strength and the great imaginative ways that we brought to things, we could solve every problem. And we've come from that to Powerball. And I think that's a terrible kind of message that we send our children. And so this kind of craziness in which the government sponsors the idea that we're going to get something for nothing and then wonders why the hell children don't have any idea that they're supposed to study and do hard things is something that troubles me. Let me speak for one second just about family life because I think it's such an under-articulated discussion in America. I'm very proud of a number of things that the American Bar Association has done, but none more than something called the Partnership Program, which is a program sponsored by the Family Law section of the American Bar Association, and it was featured in that very Time magazine article. And it's a program in which the family lawyers, the lawyers that deal with divorce, in fact, are going into high schools around the country and trying to teach high school students what it is to have serious and long-term relationships and what the marriage relationship is all about, how to decide when it's right to be married and how to stay married. And again, we have a whole society in which there's no model for that for most kids, and it's necessary for us to begin to teach that in a serious way. I think we have a problem when it's only okay in the media to respond to Dick's very good point, to have people who speak for values if they're moderately retarded like Forrest Gump. And I think that it's time for us to feel more comfortable, all of us, but particularly those of you who are here from the media today, in celebrating true American heroes of full intellectual potential who also managed to put family life first on their agenda.
I am struck by the fact that one of America's most popular television shows, Mighty Morphin Power Rangers, has been banned in Sweden as overly violent. I'd like to ask our panelists, in order to let most of our questioners get questions in, to have our panel responses be a little shorter as well, so that we can give our questioners full opportunity.
Hi. My name is Florence Koplow. I'm a mid-career student here at the Kennedy School. Your response was a perfect segue to my question about partnerships. We know that the AARP is a very powerful organization, and I'm asking the panel what you think of the possibility of promoting an intergenerational partnership between the elderly and children as part of our struggle to save our children. Thank you.
It is, just to note parenthetically, good demographic work that's been done recently suggests that the per capita spending on old people has risen over the last 20 years, even while per capita spending on children has declined. So the question is particularly appropriate. Who would like to take a first crack? Bob?
Let me just very briefly point out that I think I agree with you that this is an appropriate time to do so. The AMA is asking this country to begin a more serious dialogue as we look at the Medicare program. And is this program, an entitlement program based on age and not need, going to lead us into the most serious intergenerational squabble we've seen in a long, long time? It's hard for me to justify why the 25-year-old father of two working here in Cambridge has to pay through his tax dollars the health care benefits of Lee Iacocca simply because Lee Iacocca is over the age of 65, and yet that's what Medicare is in this country today. I sense from discussions we've had with AARP that the time is riper than it ever has been to look at such things as income-adjusted premium, tax on benefits, etc., for the more affluent members over 65, in order to free up dollars that will be useful for other parts of our society. I think you will find a strong overt political desire not to do that, because this is part of the promise to those who have made it to 65, and that is not easily going to be given up. On the other hand, the mere fact that their own trustees of the Medicare Trust Fund tell us that by the year 2001, the Medicare program is totally bankrupt right now. Totally bankrupt. We need a short-term fix and a long-term financing mechanism that will have to bring together all generations if we're going to continue to make that commitment down the road. We're hopeful that as part of this push by the Republican contract and part of the scrutiny of the Medicare budget, even though the President says he's not going to touch it, there's no question that it's going to have to be looked at. It's one of the largest discretionary dollars programs that still exist in terms of the way it contains some costs, that I think that dialogue will soon be upon us. And I think it's time. It's time we revisited that issue.
I'm Henrietta Davis. I'm a member of the school committee in Cambridge, and I want to speak for another unrepresented group on the panel and ask you how you see the role of the schools, where most of the children spend most of their time, in solving these problems.
Well, the schools are, I'll just speak from my own personal experience. The schools are very, very important and could play a critical role in the lives of children beyond learning. My experience has been one of great frustration in working with the public schools. For some reason, the typical superintendent isn't particularly interested in the kinds of partnerships with human services and healthcare institutions and law enforcement agencies that many of us are interested in. But also my experience has been that as one goes into individual schools and starts to deal with principals and with teachers, that one can find quite a lot of energy around these issues. I've never understood why the hierarchy, at the highest levels, find it so difficult to really partner. I think in part it's because they have some turf problems that they need to work out. This has been the problem, at least in Massachusetts. I'm not familiar particularly with other states in this regard. There have been some interesting and important experiments around here that have worked with kids who are in trouble. Boston actually has probably more alternative programs for kids who are not making it in a traditional classroom setting than other communities in the state, actually. And I think that the support that we've seen over the past few years, both from the state and from the city of Boston in this regard, has been a factor in reducing the level of violence in inner city neighborhoods. You can take a look at the Boston statistics, homicide statistics, and you'll be very surprised to see that they've been cut dramatically during the last 5 or 6 years. We used to have about 150 homicides routinely, each year here in Boston, and that's down around 70, somewhere it's hovering between 75 to 85 now each year, and that represents some real progress. I would argue that the schools have played a role in this because they've been targeting some of those kids, and they've been working well at the within the high schools themselves and junior high schools with the law enforcement agencies and social services agencies. The other point that I want to make is that if there's anything we've learned around substance abuse prevention and AIDS prevention and transmission of sexually dangerous diseases generally, it is that you can't intervene too early on these issues in the lives of children. And so I like to see, prevention programs at the youngest possible ages, and I think that can be best done within the public schools. I think the education community is awakening to that, and those of us who are in healthcare and human services need to support them in doing that.
I'd like to just add a comment. I agree that schools can play a very valuable and important role in helping children develop in ways that we would applaud. However, I think we need to be careful about not trying to demand too much of teachers in a time when classroom sizes have once again risen in many states, as in California, to levels at which a teacher has 40 students to cope with little assistance. We can give that teacher all of the technological tools, the training, the curriculum materials that we want to, but if they don't have the time to spend with students, then they're not going to be very effective. I also think we need to begin to involve more effectively parents and the community in the development of curriculum and in teaching in the schools as well.
Bob? I want to let you know my oldest daughter is a high school principal in Maine, and she's would echo Dick's comments that although they're very empathetic with what we are asking for, what they can provide, however, is a place. It's a place where kids are going to be. And I think we need to look seriously again, certainly at certain parts of our country where school-based health clinics may provide the primary source of health care for children in this country. Clinics not staffed by teachers, but staffed by health professionals. I'm reminded of one particular successful program in Mississippi. A good friend of mine, a family practitioner, was frustrated with an extremely high pregnancy rate, was able to take 5 schools, find the funding for 5 permanent health nurses in the school system, create a clinic where this doctor had daily presence, and the nurses could report to the physician on a regular basis. It was a good relationship that over a 2-year period of time they were able to reduce by 2/3 the teenage pregnancy rate in that community. The individual, the nurse, the person who was there at that school every day became the parental figure, became the one who was providing advice, was filling in the blanks where they were not getting information, were not getting and establishing a relationship otherwise. Now, that isn't going to work every place, but I think an extension of that from the school to some of the neighborhood health clinics that was part of our debate during the health system reform, part of the moderate package that we were hoping we might get passed as the Roland Bilirakis bill. Didn't make it out of committee either, but I think we need to relook at how many of those other opportunities we have, utilizing a structure of the school and the educational system where we're mandated to be every day, and supplement that with those whose background is not primarily in teaching but in health education. I think that may give us the biggest reward on our dollar.
You may also be interested that in states other than Massachusetts, there are some very interesting experiments integrating schools, juvenile justice, community service agencies, designed to produce really integrated case management across agencies, which does, however, require some real flexibility on the part of traditionally separate bureaucracies. Ma'am.
My name is Adriana Colon, and I work for an agency that's under contract with Boston Public Schools and Head Start to provide mental health counseling for the students and the parents. And to be honest, my MSW, my LCSW, pales in comparison to a first-year medical student in a hospital. Parents and teachers and all other faculty members say, well, let's not just get this kid medicated, give him some Ritalin. And all my educated knowledge, I come up, no, we need to have some changes in systems. Is the AMA recommending that medical students have extra classes, that teach them to, let's listen to the social worker who's been working with the family for 3 or 4 months and then has only seen a doctor this first time. And secondly, even, and this is a social worker's dream here, this panel, that I understand there's a committee for 1996. Are there any ideas for us, concerned parents, citizens, and social front workers, any ideas to implement any kind of services or plans now?
Did I hear you say that doctors don't listen to social workers? Let me give you one example of where I think we are indeed looking at social workers and trying to use our system. The AMA is one of the parents of what's called the Joint Commission that accredits healthcare organizations. I was a commissioner on that group for 8 years during my tenure on the board. And being frustrated and not seeing, if less than 10% of the time do professionals in an institutional setting take the extra time to establish this as a victim of domestic violence, we have a problem we have to deal with. And so one of the standards that the Joint Commission now has and I should tell you that it was passed during my tenure as chair of the Standards Committee, was that not only must you be able to treat victims of family violence, but you similarly must have within your institution or your community resources to refer that individual either through a psychiatric social worker, through a psychiatrist, through a psychology resident, to a battered women's shelter, or to whatever resources available for the ongoing assistance and planning to escape if that's what's necessary, or whatever resources that particular individual is going to require. It's no longer enough to say we will remove your sutures in 5 days and get you over this laceration or this cracked rib. We've got to look beyond that, and I think by and large the institutions have accepted that as a part or an extension of their natural reason for being in any given community. And I think it's one example where I think particularly those who have devoted their careers to social work now have a very close relationship with the primary care physician who is then referring to them and knows that their patients will receive the compassionate understanding that goes along with it.
Roberta?
One of the things that we're looking at very seriously as a kind of paradigm for courts that deal with problems with juveniles and family court problems as well is a model in which at the very place where the judge is hearing the case that involves the juvenile delinquency charge or dealing with a custody issue or a dissolution of a family, we actually have social workers right there and psychologists right there in the courthouse to help deal with some of the sequela of some of these things. In terms of the schools, I want to say that just as the courts and lawyers and physicians have been given by the society a whole set of problems that we weren't really trained for, so are schools being asked to deal with a whole world in which the system was never set up to deal with that particular problem. I think it's going to require a great deal of persuasiveness on all of our parts to do a whole manner of things. One is that there's a lot more to learn than there used to be. Those of you who are here in the medical school know that the kind of biology text that you had as undergraduates was 10 years fatter than the kind of biology text that physicians had in medical school. And what we're finding is that people who get poor education, especially in the sciences and in mathematics, early on are simply read out of the society because it's too hard to catch them up. At the same time, we've decided that certain things are frills that those of you in the educational world know is not correct, especially when you're talking about children at risk. For them to be at schools where they don't have an opportunity to express themselves, for example, through art, music, and sports in an appropriate way, is a kind of reading of them out of the educational system. So I think we're all going to have to be a whole lot more flexible, and given the money that we have in this country, we're going to have to insist on a whole lot more economic efficiency from all of our institutions, including the schools.
Hi, my name is Vicki Hamilton, and I do want to commend the Mass Medical Society Student Section for their second annual meeting on children welfare and violence. However, my frustration is that too often these conversations happen outside of the classroom, and a couple references today to professionals that aren't prepared to deal in the social context that you guys described so well means that we need to do some reforms at the professional schools. Curriculum changes, better recruitment of minorities.
Your question.
My question is, what sort of reforms would you like to see happen, and how do we get the professional administrations to be more responsive to change?
Let me start by telling you and reminding you that the AMA is the only organization that since our inception has dealt with and been responsible for accreditation of medical education at the undergraduate, the graduate, and the postgraduate levels. Still is. A major part of our budget goes to certifying and accrediting medical schools, residency programs, and CME in this country. Through our section on medical schools, we have now begun an agenda, a curriculum base core program that will add violence, family violence, child abuse, domestic violence as part of the ongoing educational responsibility of a medical school, and be subject to accreditation decisions if they have not incorporated that. We want to see young students, young physicians coming through the system asking questions in a non-pejorative fashion, as routine as, tell me, did you have chicken pox and measles? Do you smoke? Do you drink? Tell me, we all have violence in our life. Does violence impact on your family life, etc.? In a non-pejorative fashion that will become so routine that, given time, we will have every physician in this country attuned to doing that. And I think we have a mechanism by doing that. Like our section on medical schools that meets twice a year with our House of Delegates gives us an opportunity to do that, as well as working through the other educational opportunities that we have on a regular basis. For those of us old poops down the road, it's hard for us to go back and revisit that and begin to ask some of those questions. But it's no more awkward than the awkwardness we went through when the sexual revolution took place in this country and we had to start asking very sensitive personal questions about sexual behavior. The same kind of thing of those of us who trained prior to the use of recreational illegal drugs in this country, in the time we had to go back and ask those sensitive questions as well. I feel more comfortable about the ability to embrace the impact of violence, child abuse, etc. Now, even though it's 20 years after Henry Kemp first described a battered child syndrome, but I think we're getting to that point for the rest of our society as well.
Thank you.
My name is Dr. Wiesen. I'm from BU School of Medicine. And Dr. McCaffrey kind of answered my question right there, but I'll ask it anyway. And I teach behavioral sciences and dentistry. And I need to know what you feel is the physician's responsibility specifically when the physician suspects alcohol or drug abuse in a patient, and is the physician of today emotionally trained to deal with that situation? Thank you.
I can't answer the latter part of that. We try and separate, as you know, the emotional response from one's professional responsibility, and hopefully, although we want that to be part of the equation, we hope that the professional responsibility will exceed any emotional concern about not asking or getting involved. I'd like to, you said dentistry. Yeah, let me congratulate the American Dental Association, because as partners in our advisory committee on violence, it's surprising that you bring to this table a significant ability to detect hidden abuse by virtue of what you do. And there's a marvelous program the American Dental Association has for their members, professional education, in pointing out to them areas in which they can identify violence that has occurred to this individual through the face, the mouth, the teeth, the teeth, etc. And I congratulate you on that particular endeavor. I'm constantly amazed at what professionals in any specialty can bring to this equation, and it gives me an opportunity to make the one statement that I think is one of the more profound statements ever made to me as I've been involved with the Family Violence Initiative. It was made by a 38-year-old cardiologist from Kenosha, Wisconsin, who was instrumental in establishing a battered women's shelter in his community because of the need that he saw, even though he primarily was a cardiologist. And I met him for dinner the night before we had a press conference, and I said, "Kevin, I understand that you're a cardiologist." He said, "Yes." I said, "But I also understand that you treat battered women." And he said, "Yes, and so do you." And I think that's the most profound statement I can give to any physician who treats adult patients. We can say that within the last 2 weeks, you've had in your office at least one victim of domestic violence. Who was it? If you don't know, if you haven't asked, you're not going to find out. And we use little tricks like saying, if a woman calls my office in Portland, Maine, and makes an appointment, and a man calls and cancels it at any time, we flag that chart, put a little black and blue sticker on the inside of that chart. And if that woman subsequently comes to my office, there's a 50% chance she's a battered wife. Now, it's interesting, we have a 5-man group, and my other partner's experience isn't nearly as high as mine is, but it's well known in my community that I have a concern about family violence. It's an interesting observation.
We're getting to the end, and I'd like to get another 1 or 2 questions in, so, ma'am.
Yes, I'm a parent, and I have to say I'm truly pleased to see all of you with your expertise try to join together to solve some of the problems for our children. Dr. McCaffrey and I spoke at break in regards to the issue on circumcision and the fact that the United States is the only country in the Western world that routinely does it. In the 1980s, we did approximately 86%. We're now down to about 56%. What the medical community is finding out is that there are a 20 to 50% rate of complication that has arisen from this surgical procedure. And the American Medical Association...
I think we're getting into a
Okay, what I would like to do is ask the American Medical Association, along with the Mass Bar and Health and Human Services, what they're doing to educate the medical community as well as us as parents, because I only found this information out a week and a half ago through a lot of research.
Thank you.
And we need to know.
Dr. McCaffrey?
I think, as with all procedures, the more we know, the more we're able to share with our colleagues. And I think that the reducing incidence of circumcision in this country is one which reflects by and large, the understanding of the procedure, the benefits, the disadvantages, and the complications that when it's done inappropriately. As you know, we have taken a stance that female circumcision is a mutilating procedure and shouldn't be done in the world, and we've taken some leadership through the World Medical Association in trying to get this procedure condemned in other parts of the world, including this country. I think your point is well taken. I think with any procedure we need to revisit its merits, its disadvantages, its need, and as we learn more about problems, we can begin to understand and try to share that information. I think the informed consent that is now available to parents of newborns provides more information than ever before in the past. As to whether that occurred in your case or not, I'm not able to say, but I will tell you that it's, from what I see across the country, far more than used to be there in terms of this particular procedure.
Well, I'd like to ask this gentleman who's been standing here a while to ask a question. Then I'm afraid, because of the time, I'm going to ask each one of our panelists to offer some closing comments. So you get the last question.
Thank you. We've heard this morning about sweeping changes happening in Congress to cut resources to disenfranchised children, and we're becoming aware of increasing sentiments across the country to reverse hard-fought social reform. Proposition 187 is one such example of targeting defenseless groups, specifically immigrant populations. Given its ramifications in medicine, law, and public health, I'm interested in the advice of the positions of the panel, of the panelists on Proposition 187, and I'd also like to ask for specific examples of what we as medical students or students in other areas in law and public policy could do to combat changes that are happening right now.
Prop 187. Shall we start at the far end?
Well, the Clinton administration, the president opposed Proposition 187, but I guess that's the answer to your question from my point of view, and that should suffice.
Dick?
The Proposition 187 is now in abeyance. It's in the courts, and the courts are going to begin hearings on this case in the near future. One of the things that many health professionals in California did leading up to the election was to state very publicly that if it passed, they would not report immigrants who came into their practice to the immigration authorities, that their responsibilities were not to be immigration police, but rather to be health professionals. And I think that was an appropriate public action, and it was a hint of civil disobedience, which I think is an appropriate action when your professional responsibilities are, you're asked to violate them as a matter of law. I also think that it is important for us to mobilize our considerable political influence. Too many of us watch these things occurring. We read about what's going on in the Congress. We may feel strongly about it, but we don't act on our views. We think that, well, somebody else will take care of this, or my views are inconsequential, or I can't have any effect. And I strongly disagree with that. I think we can, as individuals, when we write a letter to a member of Congress, that letter is at a minimum counted. Occasionally, very occasionally, it's actually read by the member of Congress, but it's certainly read by the staff and responded to. Secondly, I think we can through our organizations, your student organization, and through the AMA and through other professional organizations, to take action as an association. The American Public Health Association is not a rich organization in terms of resources, but we spend a considerable portion of our resources in the area of government relations on behalf of the public's health. And one of the things that the APHA is known for on the Hill and respected for is that when we go to testify in the Congress, we do not go on behalf of the self-interest of public health professionals, but rather we are viewed as coming to represent the needs of the public's health. And I think that when an association takes positions on broad issues of concern, it gains that kind of recognition. And finally, I think we need to act as citizens in all of our different roles and capacities when voting in our churches and synagogues, community organizations, to also raise these issues with people, alert them, and urge them to also become involved.
At the House of Delegates meeting that we just had in February, the American Bar Association took a very strong stand against the implications of 187 in particular as it dealt with the problems of, that it would rest upon the backs of children. At the same time, I think, to be honest with ourselves, we have to look at who voted for Proposition 187. And interestingly enough, I have somebody checking these statistics, and Dick, you probably know the answer to me, but somebody told me that 51% of the Asians who voted in favor of Proposition 187, a third of the Hispanics, and I heard a very healthy percentage of the African Americans in California. And so I think what that's telling us is that there is a concern about the nature of illegal immigration and the kind of burden that is on the border states, and I live in a border state, that we have to be real serious about. In my own personal view, part of the problem is that, like a lot of other things, we haven't directed our resources very wisely in dealing with that, and so we're dealing in an inappropriate way with the sequela of some of the things that we've done. I was very pleased to see the course that the courts in California took in really stopping instantly the kind of draconian measures that Proposition 187 suggested, but I think it would be foolish for all of us as a nation not to understand the underlying message that we're getting from votes like that.
Just to let you know that both the AMA and the California Medical Association strongly opposed 187, and we're ready to stay in court if necessary to be sure that the professional physician is not put in a position of substituting for an immigration policy in this country. I agree with Roberta that we saw in that vote a lot of the gangplank theory. You know, I'm aboard, let's pull up the gangplank, and we saw a strange coalition of people voting in support of that. I think the whole issue does beg for a much more comprehensive understanding immigration policy for this country, and unfortunately this may not be the makeup of Congress that we would select to make that at this time.
Before I ask each of our panelists to say a final word, I want to say something briefly that I think Roberta's comments provoke. There's always a danger in an audience of people who self-selected themselves for positive concern with an issue like this, that an aura of political correctness and false unanimity will enter into the proceedings. And as Roberta said about the immigration issue, and as was said earlier about welfare reform, I think it's very important for people who take seriously the concerns of families and children not to lapse into the kinds of self-righteousness and indeed sometimes even deafness that has helped produce the sort of political circumstances which we now confront. A great many of the things which we do have not necessarily worked as well as they should, and inflexibility in defense of the past, it seems to me, is not likely to be the course of action which will produce maximum benefit for the kinds of vulnerable groups that have brought us all here together this morning. With that, I'd like to go back down and begin with you, Phil. Any closing words?
Well, I don't have any particular insights beyond what I said. I guess that I feel this is a very, very dangerous time for children in the country. I tried to separate in my remarks the between the responsibilities that we as individual citizens have and the responsibilities of institutions and particularly the public sector, various levels of the government. We can get all embroiled in the details around block granting of these programs or the specifics of welfare reform, or whether or not school lunches should be funded by the federal government, or whether there should be an entitlement, continuing entitlement for Medicaid or for AFDC. But I think one sees in a kind of broad, sweeping way when one looks at what's happening in Washington, what can only be characterized as an assault on poor children. Not children generally, particularly, but poor children. That doesn't mean that those of us who support some of the programs that have been built up during the last 50 or 60 years in the country don't support innovation, experimentation, and change. Certainly some of them have not worked effectively. But I would remind you that the nation is a much better nation today than it was before Franklin Roosevelt became president. And we have a safety net, and we have a situation in the country today in which children and adults, for that matter, who are in poverty are not literally starving the way they were prior to the advent of the New Deal. It doesn't mean everything that the New Deal stood for, and John Kennedy and Lyndon Johnson and all of my personal icons were right about everything. Obviously, the world is different. We have new problems. Many of the problems that we see, as we've discussed this morning, are in the healthcare arena, whether it's substance abuse or AIDS or handguns or low immunization rates in our inner cities. but it does seem to me that many of these cry out for a strong, aggressive public response, and that we need to hold the feet of public officials to the fire to the extent that we can, to remind them that there is a strong constituency in this country that cares about families, that there are a lot of people in this country who care about the federal role and the state role and the local role in advocating for and providing protection to some of the most troubled and vulnerable children in our society. And I hope that all of us will work together to do just that.
I think one of the things that we need to do is what you folks are doing right here today. The fact that the student section has organized this meeting, I think, is a very positive sign. It's a sign that people are concerned about an issue, that they're taking time to learn about it, and to begin to act on that issue. And I think that's a critical role for all of us as health professionals and other kinds of professionals. I think that needs to be part of our training and our education programs, that kind of encouragement and that kind of support to do those things as well. I also think we need to act on these new skills and the new concerns that we have as professionals, and that means we need to also shape the institutions in which we work to help facilitate that process so that the institutions are not mobilizing against it. When a physician goes to work for an HMO or another institution that says you have 6 minutes to spend with each patient on average, you don't have very much time to ask questions about the person's experience with violence or with drugs or alcohol. Your time becomes so compressed that it's difficult to do the things that you've been trained to do and that you know you want to do and should do for your patients. Finally, I think we need to be concerned about public policy. Public policy is not the solution to all of our problems, but it's an important support to finding the solutions and implementing the solutions that we believe are necessary for children in this society. We need to adopt and advocate for policies which make the healthy choice for people, and adults and children alike, the easy choice, so that those things are facilitated by our public policies, not made more difficult, and to make the health-damaging things, be they handguns, tobacco, or alcohol abuse, more difficult to pursue. I don't think either that that means that we need to defend every program that's out there that's being criticized today. I certainly do not advocate that, and neither does the American Public Health Association. Although categorical programs have provided important funding to the public health infrastructure throughout this country, funding that's passed through CDC, Centers for Disease Control, to state and local health departments and community agencies, we do not defend categorical programs per se. Rather, we feel it is important to establish a certain set of standards of accountability and of adequacy of funding and of effectiveness in program implementation, and examine each proposed change in those terms rather than a knee-jerk response that says, we've had categorical funding, it's supported public health, and therefore we should retain it. We favor examining all of these programs and moving toward greater effectiveness, but with assurances about accountability and effectiveness as well. So I want to commend all of you for being involved in this, and especially those who took the time to plan this really excellent symposium, and to encourage all of us to continue these kinds of efforts into the future.
Well, I am, in spite of all the pessimistic things we've been talking about today, enormously encouraged in a variety of ways. First of all, it is just wonderful to look out at all your beautiful young faces and to have you understand that those of us who are cosmetically challenged are sitting here together because we honestly have come to the point where we recognize that our human needs as a society are the things that join us all together. What's most important, I think, for me to tell you is that as you go through your training, your medical training, your legal training, don't forget that you don't want to lose your own humanity as you go about saving ours, and that there is absolutely nothing incompatible with having a razor-sharp intellect and a compassionate heart. And in fact, that's what I expect of each of you.
Three quick points. Let me be sure to point out, because this is being taped, that I acknowledge the fact that men are sometimes victims of domestic violence. If I don't say that, I get mail. I get all kind. I get picketed.
I get mail even when I do say it, Bob.
But I get less when I say it. And I'll point out to you that although men sometimes are victims, that the magnitude of the injuries is far greater when the male is the perpetrator, and I think we all understand that. Secondly, I'm totally convinced that the solution to this problem will be because of coordinated community efforts across this country. It's too important a problem to delegate to Washington. It's too important a problem to let the national AMA and ABA and other national organizations feel they are to be the solution. Ultimately, what happens will be what you carry to each and every community that you choose to live in as citizens, as professionals, for the rest of your life. And the commitment to assure that that community remains free of violence, protective of children, is solely proportional to your degree of commitment when you get there. And there's no way you can escape that responsibility. And lastly, we'll finish with many of you we use terminology in our language all the time that we tend to forget its derivation. One of the terms is rule of thumb. The rule of thumb dictates this, the rule of thumb dictates that, and many of us forget the derivation of that term. It came to us, I understand, from Old English law, where the king granted to the taxpayer, usually the man of the home, the right to maintain law and order by beating one's wife or one's children with an instrument no wider than your thumb, be it a stick, piece of leather, cat of nine tails, etc. I submit to you after this morning, and with your leadership from this point on, that you'll join with the AMA, the ABA, the Public Health Association to help amputate the rule of thumb from our lexicon. Thank you very much.
Thank all of you for coming. Thanks again to our panel for such a stimulating discussion, and good afternoon.